I think we're live on YouTube as well.
Morning, Surinder.
Good morning, sir.
Satish, could you respond? Can't find you in the ID here.
He's on the
Surendra sir, morning. Could you share screen if you have any presentation? Satish, let me know if you're in the meeting.
Yes, sir.
Yeah. So, yeah, I think you've joined as the other name, right? All right.
Yes, sir.
I'll just put you as the host. Just make me the. I'm just renaming you.
Yes, sir. I'm renaming.
Want me to share the screen?
Yes, sir. Please do, sir. We'll test all this before we begin.
Yeah, 1 minute.
Sir, I'm making it as a APT series.
Okay. Can you see Sri Krishna?
Late, sir. I can't see anything as of now.
You can't see? Why
Late,
not
sir.
see?
Oksari, Malli share chend. Yeah, just started. The message has come. Let me just wait. Satish, just raise your hand once. Full screen, Ellen, sir.
Okay, you can see.
Yeah, confession, sir. Oksari full screen slideshow, Ellen.
Okay.
Yeah, great. We're all set. Surendra,
Okay.
sir, you can stop screen share. We'll begin the session.
Okay.
Great. Thank you. Anyone else? Any of the other faculty who needs to share screen, just let us know. Right.
I think you need to talk to Dr. Dania Dharmapalan.
Madam just shared her screen, sir.
Okay, then.
Yeah. I think we're all set.
Yeah.
If we're all set, we'll just begin. I'll just change the setting and we'll begin. Namaskaram, everyone, and welcome to today's IAP Twin Cities branch symposium. Today's symposium is very special. It's about dengue fever. And before we begin, let me convey warm regards on behalf of entire executive board for Azadi Ka Amrit Mahotsav, the 3-day celebrations celebrating the 75th year of independence. I hope you all have a very happy Independence Day, and please join the rest of the country in celebrating this momentous occasion. Thank you for all your support to IAP Twin Cities branch programs. We request you to participate very actively in the upcoming Central IAP workshops, which we'll be holding, and also in the further events. Coming back to this particular session, back in postgraduate days, we were told if there's one disease that will determine the success of your practice, it is dengue fever. This is one illness which is most misunderstood, highly overtreated, and the secret is to know which one to send back home with a multivitamin or to send to a hospital for admission. And these decisions, they determine the way in which we are practicing pediatrics and also how parents are able to handle their kids back home. It's always been an enigma, and I'm very fortunate to have very experienced faculty today to take this session over the next 2 hours. My pranams to also Venkatesh sir, who has joined us today. Warm welcome, sir. I'll now request our president, Dr. Sunkoj Bhaskar sir, to give his inaugural remarks. Bhaskar sir, please.
Thank you, RSV. Respected Dr. Venkatesh sir, respected faculty, and the distinguished participants. Good morning to you all, and welcome you to this 8th IAP Twin Cities Branch Symposium on all about dengue and update. As you all know, we have been doing it every month on one particular subspecialty. Even in that subspecialty, we are digging down into a single topic and highlighting for more than 1 hour, followed by a panel discussion on that for another 45 minutes. So here, the reason for taking up this dengue is, in fact, I thought of doing on infectious diseases. When I spoke to Dr. Sanjay Srirampur, as I do always, he had suggested me the single best possible topic in infectious diseases, none other than dengue infections. I was very much impressed, and we went ahead because 25 years ago, at least I didn't hear much about dengue, but since last 2 decades, we are coming across so many dengue infections. And as Dr. RSV said, I still remember 15 years ago when platelets were going below 60,000, we used to give platelets repeatedly. Now I realize how foolish I was. So like that, so many rapid changes took place. And now during this monsoon, we are seeing so many cases of dengue. For any febrile illness, dengue is also coming into our mind. But fortunately, 80% of them are either mild or asymptomatic. And still there is a risk of outbreaks across the world, particularly in our Asian continent. And hopefully we may get a vaccine to that. For this important symposium, we have a befitting faculty led by Dr. Sanjay Srirampur. This is his brainchild. So I'm sure all of you know, he is our advisor for the IAP Twin Cities branch. And for me in particular, in person, whenever there is an issue, I discuss with him and he guides me. And he is our editor-in-chief of our prestigious IAP Twin Cities branch monthly journal. And he was the advisor of the recently held IAP Central Zone Pedicon 2022. And thank you, Dr. Srirampur. You are the director and as well producer of this movie Symposium, Dengue Fever. And we are very fortunate to have our Dr. Vijay Yavle. As you all know, he's our national president of IAP in 2014. And he's very much interested in infectious diseases and vaccinology. I must have heard not less than 15 of his presentations in conferences and as well at Hyderabad. Thank you, sir, for accepting our invitation. And Dr. Surendranath, another face of our IAP Telangana state and as well Twin Cities. He's a nationally recognized speaker. We are very fortunate to have him. And he was the vice president of IAP Central Zone in 2020. Dr. Dania Dharmapalan, again, a rising star, well known across the nation. Presently, she's a consultant at Apollo. And she's also, as Dr. Sanjay sir said, she'll be a very suitable person for this presentation. She's interested in infectious diseases and rational usage of antibiotics. We have Dr. Erra Anupama. She's an intensivist working in Rainbow Children's Hospital. And I forgot to tell, Dr. Sanjay Srirampur is the director of academics at Rainbow Hospitals, Hyderabad. Now coming down to the panel discussions, we have Dr. Vijay Shekhar Reddy, very experienced, a great pediatrician. He managed well the office practice. He is the CEO of Bloom Hospital, Kompally, Hyderabad. We have Dr. Ajay Mohan, is the Professor of Pediatrics, Gandhi Medical College, and as well a unit chief at Gandhi Hospital. We have Dr. Nitin Chawla, less known in Hyderabad, but well known across the nation. His main area of interest is acute care and critical care. And he did a lot of works in pediatric emergency care. And unfortunately, we are missing Dr. Shamsundar Toshniwal for some personal reasons. He is unable to attend. And with these few words now, did I forget anybody, sir? Sanjay, sir?
Dr. Bhaskar, you are bang on target.
Thank you, sir. So now just a word about our IAP TCB activities, sir. Since last January 1st, without missing a single program, like we do 3 important activities every month. One is IAP TCB Symposium. We are doing it successively without giving any gaps. We have IAP TCB PG clinics, wherein a resident will be presenting a long case. It's like a final exam of pediatrics. And we have IAP TCB clinical meeting, wherein 4 briefcases are presented. In addition to that, in July and August, we are very busy with our IAP Central Zone conference. I think which went on very well, very smoothly and successfully. And we were very busy with CPR week, then ORS week, then feeding week celebrations. I'm thankful to all the EB members and all the members of IAP TCB for actively participating during these week celebrations. So with these few words, I wish you all a great knowledge sharing and learning experience. And I wish you all Azadi Ka Amrit Mahotsav yesterday, today, and tomorrow. And wish you all a great, happy Independence Day tomorrow. Thank you all once again. Thank you. Over to Dr. RSV. If Dr. RSV is not there, I request Dr. Sanjay Srirampur to take over and conduct the proceedings. Over to you, sir.
Good morning, President Dr. Bhaskar, Dr. RSV, my teacher, Dr. Alladi Venkatesh, sir. Sir, your presence is a blessing for all of us. What a nice day today that post-pandemic, our clinics are again jingle bells, and we have only 2 sorts of cases which are there now. The first is we are seeing plenty of rashes like hand, foot, mouth, rashes like herpangina, rashes probably monkeypox. The other type of cases which we are seeing, for which we are scared about, is dengue fever. So before I open this topic for discussion, I thought I'll place before you 3 issues or 3 foods for thought before we really start discussing for the next 1.5 to 2 hours. Let's go back in time. Let's go back in time to pre-COVID times. Pre-COVID times, that was way back in 2018, 2019, all of us thought that probably infectious diseases are taking a back bench. Even the government also thought that we now need to focus on preventing or reducing child morbidity. We had the RBSK program. We focused on metabolic diseases. We focused on child development. We focused more on genetic diseases. But we focused on subspecialties. We focused on corporate hospitals. We somehow relegated primary care to the back benches. But this little bug, the COVID virus, brought it all in one place. We started again focusing on infectious diseases. We realized that we probably forgot preventive medicine. We realized that probably our focus was more on subspecialties rather than infectious diseases. So it's all a circle which has happened. And believe me, now if I see patients, They are so specific. Yesterday, I saw one patient and the patient said, "Doctor, I'm sorry." I said, "For what reason you are sorry?" "Doctor, I'm sorry because I'm not wearing a mask." So the focus is so much that everybody follows the SMS, the social distancing, the masking, and the sanitizers. The second food for thought, which I thought I should put in front of you, some facts related to dengue. There's a very nice publication which just came about 2020 from WHO, which states that 2.5 billion people, that is 2/5 of the world's population, are susceptible to dengue fever. There are 50 million dengue infections which occur worldwide. For a minimum of 5 lakhs, individuals require hospitalization because of dengue hemorrhagic fever. And surprisingly, dengue is increasing in frequency, as Dr. Bhaskar rightly told, way back in 2002. To diagnose dengue was a challenge. I remember seeing challenging cases at that time, suddenly sinking without our knowledge, and then realizing that it was dengue fever. Dengue is primarily an urban disease, but now it is making inroads into rural atmospheres. Dengue is a challenging disease in the sense that it's not one virus or the one serotype which circulates. There are plenty of serotypes. There are 4 types of serotypes which can circulate together, and each serotype has got different genotypes to change its colors and affect us. Now, the third issue which I thought was a food for thought I should present before you was about a week back in my clinic, one of my friends had a doctor. She had come from US, and she told me, "Sanjay, me and my family are coming, and you know how much we are spending money and preventing malaria for each of us. We are spending $144 per head." I said, "You are wasting money. We are not seeing so much of malaria." In fact, I would also like the comments of the different panelists and faculty today. Somehow malaria has gone at back benches. We are seeing more of dengue fevers. So I told her that you need to prevent yourself from dengue fever. Malaria is not a scourge at the moment. And the second thing, which was quite intriguing, I'm sure many of practitioners like me who practice general pediatrics share with me that our Indian mosquitoes are very fond of NRI blood. So they bite more the NRI's children than Indian children. So there are so many confusions, there are so many enigmas, there are so many challenges, there are so many issues in a common fever like dengue fever for us. When to hospitalize, what are the critical signs, what are the warning signs, do blood products have a role in the management of dengue, how frequently we need to monitor the CBC, do we need to do protocol-based management for all, or do we need to do a case-based management? And we have with us a very wonderful faculty, very senior. Dr. Yevle, my very good friend, is there. He has very gracefully accepted our invitation. We are lucky that Dr. Yevle is in Mumbai probably, and he has time for us for the next 1 or 2 hours. We have one of the finest infectious disease specialists in the country, Dr. Dania Dharmapalan. She is associate of Dr. Vijay Yevle, and recently she has been in the news for her wonderful article on inactivated polio vaccine along with Dr. Jacob John. We have Dr. Surender, my colleague, my friend, who breathes, drinks, eats vaccines, and his WhatsApp messages are the latest. We have there are few students of mine who are there today, and it's a pleasure to have them. Dr. Anupama was one of the finest students of mine. She did her DNB under me, and she has specialized in infectious diseases, and she is along with us. Dr. Ajay Mohan, professor of pediatrics, I call him Ajay. but he's now Professor Ajay Mohan is attached to Gandhi Hospital. Dr. Vijay Shekhar, in fact, of 3 years of his MD Pediatrics, Vijay Shekhar did 2 years along with me. So it's pleasure to have you, Vijay. Nice to have you here. We have Dr. Nitin Chawla, and I am told that Dr. Nitin Chawla is one of the finest critical care specialists in the city, and he is a very lucid and a nice orator. It's a pleasure that all of you are here. I now request Dr. Dania Dharmapalan the plan of the day is that we'll have 4 lectures of 20 minutes each. The first lecture will be on typical and atypical manifestations of dengue. Dr. Dania will take. The second lecture will be on office practice management of dengue, which Dr. Vijay Evle will deliver. The third lecture is on ICU management of dengue. Dr. Anupama will deliver that lecture. Dr. Surender will speak on dengue vaccine, so near yet so far. And then we'll have a 40 minutes discussion, panel discussion. I have titled the discussion Making Management of Dengue Meaningful, for which I will moderate. All the speakers will be a part of the panel. In addition, Dr. Ajay Mohan, Dr. Vijay Shekhar, and Dr. Nitin also will be a part of the panel. Over to Dr. Dhanya. The screen is all yours. Dr. Dhanya, ma'am.
Yeah, thank you. Thank you. Just sharing the screen. So, thank you very much, Dr. Shirampur, Dr. Bhaskar, and the entire team of IAP Twin City for this opportunity. So I shall be speaking on common and uncommon manifestations in dengue. This is the hospital where I work, Apollo Hospitals, Navi Mumbai, beautifully lit up last night for the Independence Day celebrations, and wishing you all Independence Day celebrations. So I have a disclaimer that most of the content in my presentation today is heavily based from the WHO educational materials on dengue. So as Dr. Sanjay Shirampur was just talking about the serotypes, any person can get infected by one of the 4 serotypes of dengue in the lifetime. An infection can confer lifelong immunity to that serotype specific infection, but there is cross immunity to other serotypes. However, that cross immunity does not last more than 3 months or so. So in India, there is outbreak reported of all of these 4 serotypes, predominantly being serotype 2. Now, since my talk focuses on clinical manifestations, I shall be concentrating first on the normal manifestation of dengue. So after an incubation period, which can last from 10 to 14 days after the bite of the infected Aedes mosquito, there is an abrupt febrile phase, which comes accompanied with headache, nausea, myalgia, body ache, and rash. Some children might complain of retroorbital pain. And then is followed in subset population by a critical phase where the temperature actually dips below normal and can stay, if the child can stay afebrile and can have plasma leakage, followed by recovery phase where there is reabsorption of the leaked plasma. So the total duration on an average is about 10 days from the onset of fever. Now let us look more closely at these parameters, temperature, as mentioned, you have a febrile phase, and this corresponds with viremia, and which is detected with NS1 positivity in the blood. Then is development of the antibodies, IgM, IgG. So this crossover from NS1 to the detection of these antibodies is unpredictable whether it can happen on the third day or fifth day. The critical phase generally is seen between 4th to 6th day of onset of illness. And what happens is there's sudden dip of the temperature, and this in fact goes subnormal and below the base, and then you can have a second phase of fever in many of the children, which is called as Biphasic Fever and gives a saddleback picture. Correspondingly, the lab features show drop in WBC. The drop in leukopenia precedes thrombocytopenia, and then they both reach a nadir during the critical phase. Correspondingly, the hematocrit shows a rise. So a rapid fall in platelet, especially with a very high hematocrit, is a classical feature which in critical phase. And then there are potential clinical issues such as decreased oral intake during the febrile phase, causing dehydration, and the rise in capillary permeability, which is maximum during the critical phase. And because the kidney controls the intravascular volume of the body, because of shrinkage of the intravascular volume, kidney tries to maintain the intravascular volume by reducing the urine output. So urine output, therefore, is very critical in the entire, right from the history to monitoring and managing dengue. The plasma plasma leakage can, because of the reduced intravascular volume, the patient can go into shock, and this can also, because of these in vascular permeability, there is bleeding. And then in the recovery phase, there's reabsorption of the leaked plasma, and depending on the fluid that was received during the critical phase, there could be even fluid overload. Organ impairment ensues mostly due to the tissue hypoxia, which occurs due to the shock. And most of the vital organs any of the vital organs can be involved, right from, it could be liver, could be heart, brain, kidneys. And the recovery takes some time and extends into the recovery phase. So the transition to the critical phase from the febrile phase usually takes place between day 4 to day 7, but it can be as early as day 3 or as late as day 8, and it coincides with effervescence of fever. What is most important for physicians is to explain the warning signs to every patient, because these patients can be then identified for risk of developing shock. And these are the clinical warning signs: severe abdominal pain, severe enough for the patient to complain on their own that there is severe abdominal pain, persistent vomiting, mucosal bleed like gum bleed, lethargy. Restlessness is extremely worrying, especially if there is shock, because it may indicate cerebral hypoperfusion, hepatomegaly of more than 2 centimeters, clinical fluid accumulation. So these are the most important warning signs that every one of us must remember and counsel the patient. In laboratory, it's leukopenia, rapid decrease in platelet count, and rising hematocrit. So let us look into the critical phase where there is increased vascular permeability, which causes significant plasma leakage and thereby deterioration. And this phase is fatal if it is not treated properly. The plasma leakage duration is just about 24 to 48 hours, but we need to be timely in our management during this leakage. But however, fortunately, not all patients experience the critical phase because not all have significantly increased vascular permeability. So patients, if they with a bit of oral fluids, they show general well-being, fever subsides, but however, they may have leukopenia or mild to moderate thrombocytopenia for a few days. Now, in the recovery phase, the vascular permeability reverts to normal and gradual reabsorption takes place of the extravascular fluid in the next 48 to 72 hours. And clinically, the recovery phase is characterized by improvement in the general well-being and hemodynamic status. There could be diuresis. Some children can have a biphasic fever, may have bradycardia, and the classical rash of dengue, which is described as isles of white in the sea of red. In laboratory, the clues are that the hematocrit stabilizes. In fact, the hematocrit may dip if there is dilutional effect of the reabsorbed fluid. WBC usually starts to rise soon after defervescence, but however, thrombocytopenia may persist a bit longer. So what are the clinical problems in dengue in these phases? Febrile phase, there could be dehydration. The child might present as febrile seizures. There could be delirium due to high fever. In critical phase, because of plasma leakage, there is the danger of going into hypovolemic shock, severe hemorrhage, or organ impairment to the liver, kidney, and other organs. During the recovery phase, the problem is about hypovolemia with fluid overload because of inappropriate fluid management. Severe dengue is defined by one of these: either there is severe plasma leakage, or there is severe bleeding, or there is severe organ impairment. And in the first case, the patient has hypovolemic shock and respiratory distress can follow. That is due to fluid accumulation. It could be either pleural effusion or ascites. So just as an example, this was an 11-year-old was referred to us with breathlessness since 1 day and abdominal pain since 2 days, had fever 6 days back, had become afebrile since last 4 days. On admission, the child had respiratory distress with saturation just about 91%. The abdomen was distended with free fluid. This was the X-ray showing pleural effusion at bilateral, more on the right side. And so what is it to be remembered is the volume of fluid accumulation is actually equal to the severity of plasma leakage plus the fluid therapy that is given during the critical phase. And though the abdominal pain in dengue indicates leakage, it can also, the pitfall is that the abdominal pain can also occur if there is tense ascites with hepatitis. So it is very important to look at the urine output and then decide the further course of action appropriately. And this was the X-ray after a few days of restriction of fluids and treatment of the same patient. Now, regarding severe bleeding, the patient can remain, such patients remain in shock despite the IV fluid management, and the hematocrit is found to be decreasing. Bleeding can be occult, and if not recognized in timely manner, it could be really dangerous. So it's very important to frequently monitor the vital signs as well as hematocrit when in doubt, and the bleeding is commonly seen in the gastrointestinal tract, and very rarely does bleeding occur in brain. Severe bleeding will increase the shock further. And severe organ impairment is again due to consequence of the shock, and it is defined by WHO as the liver enzymes SGOT and or SGPT being more than 1,000 international units per liter, or impaired consciousness or impaired cardiac function with raised cardiac enzymes and reduced left ventricular function. So we had a 9-year-old child who was referred to us in altered sensorium after an episode of generalized tonic-clonic convulsion, was admitted outside with fever since 4 days, loose motions and vomiting. An outside report had shown dengue NS1 positive. On admission, the GCS was poor, E1, V1, M2, there was tachycardia. A patient was in shock with delayed CRT and a huge liver, 4 centimeter. Blood pressure showed a narrow pulse pressure. And immediately on admission, it passed large volume of malina. The counts, if you see, the platelets were not so low, but had severe hepatitis, SGOT to a tune of 4,500. And since the child remained unconscious, MRI, was done. And that showed bilateral, MRI brain showed bilateral cytotoxic edema, which involved the cerebrum as well as the cerebellar white matter, and as well as there were hemorrhagic areas in bilateral thalami. So all these features indicating dengue encephalitis, along with the severe hepatitis and bleed that the child had. We unfortunately lost this patient. And this was very unusual case because this it seemed that there was a direct invasion of the dengue virus in the brain, causing all these features. So it's extremely important for any child who is being suspected for dengue to be clinically assessed and to be able to rule out any other differential diagnosis. But it always helps to, in the dengue season especially, to make sure when you are examining your children about the mental state, hydration state, hemodynamic state, is there any clinical evidence of the warning signs that we discussed about, or any other important signs which can suggest dengue. And the reason for looking at all these signs is that the CRT, the extremities, peripheral pulse volume, will give an indication of what peripheral perfusion. The heart rate, pulse pressure, and blood pressure gives the idea of cardiac output. The respiratory rate, there can be tachycardia, respiratory compensation. And as mentioned, the organ perfusion is reflected in the urine output, and the conscious level will indicate the organ perfusion of the brain. And it is very, very important to remember that in the early shock of these patients, there could be changes in all these parameters except in the conscious level, because that's the last to go. It happens only in the last stages of shock. So the child remains conscious, otherwise in decompensated shock, and the fall in systolic pressure also takes place last in dengue. So this is very critical to remember when you are examining such patients.
Madam, you have 5 minutes to go.
Yeah. So WHO has classified dengue with or without warning signs and severe dengue. And we just discussed all these parameters about what to watch for and the criteria for severe dengue. But at the same time, you have dengue mimics, because the febrile phase can mimic any flu-like illness such as influenza, COVID, etc., or exanthematous fevers like rubella, can have infectious mononucleosis, acute abdomen like appendicitis, especially in the warning signs, and infections like typhoid, rickettsia, autoimmune disorders like SLE, hematological disorders like ITP. So a few points, leptospirosis and dengue, what's important is, though they have common manifestations, the jaundice and the renal involvement and leukocytosis and anemia is more common in leptospirosis, whereas the rash and thrombocytopenia will be more predominant in dengue. In malaria, you will have more of myalgia and rash and leukopenia predominantly in dengue than in, and of course, malaria, you have anemia, which is predominant more than in dengue. And in chikungunya, you will find that the arthritis is more common of the smaller joints, and shock is a very rare feature in chikungunya, whereas you have pancytopenia most commonly in dengue. And lymphopenia is again more predominant in chikungunya than in dengue. For acute abdomen, the fever precedes pain in dengue, whereas the fever is after onset of pain in surgical acute abdomen. There is no guarding usually in dengue, which is otherwise seen in surgical acute abdomen. And fluid resuscitation is extremely important in such dengue-related acute abdomen. But in surgical acute abdomen, the pain will continue despite fluid resuscitation. And to differentiate between septic shock, though the temperature is usually subnormal in dengue shock, but septic shock can have subnormal temperature in later stage, but the pulse volume is small or weak with narrowed pulse pressure, while septic shock has bounding pulse with widened pulse pressure. Extremities may be warm. Usually dengue shock is cold extremity. And leukocytosis is later on if there is active bleeding in dengue, but septic shock is usually has leukocytosis unless it's gram-negative sepsis with severe pancytopenia. And usually you have marks, elevated CRP in septic shock than in dengue. And in the post-COVID era, it's important to remember that MIC is another severe a mimicker of severe dengue, and authors have looked at the common manifestations, and they suggest that the oral mucosal findings like strawberry tongue and the cracked lips, raised inflammatory parameters, especially CRP, whereas ferritin is more raised in dengue, and coronary artery abnormalities go more in favor of MISC than dengue. And we had a child who was referred to us for falciparum malaria. On day 1, the test was done outside, but however, did not have any clinical features of malaria. Neither the PS showed malaria. However, we treated based on the report because it was referred as falciparum. We gave the treatment, the platelets fell. However, the fever persisted, and then the child developed rash on 4th, 5th day. Then we realized that it is dengue after all. We started monitoring the urine output, which was pretty good, but still the child had persistent fever and started looking sicker day by day. It was very unusual to have dual infection from 2 different mosquito bites. But in this case, we were wrong about falciparum malaria probably. And the dengue IgM came positive after 6 days. Ferritin was raised and we went for a bone marrow biopsy. And you can see the hematophagocytes. And this was dengue with HLH managed with IV steroids. And the last case of a mother with dengue who delivered. And on day 2, the baby developed fever, shifted to NICU, was tested NS1 positive. What is important to remember is any mother who has dengue fever within 10 days of delivery, the babies need to be monitored because initially the babies can be asymptomatic and then later have full-blown dengue, which can actually mimic sepsis. So there are many more which is impossible to cover in this short period, but there are many other unusual manifestations reported like GBS, transverse myelitis, or myocarditis, or ARDS, and acalculous cholecystitis, glomerulonephritis, and ITP. Dengue itself can cause ITP. So to summarize, dengue has a wide variety of clinical presentation, and it is dynamic with unpredictable clinical evolution. And it is extremely important to remember, it is not at all a platelet count disease. It's much beyond that. And majority are fortunately self-limiting, but it is that small subset which can have severe plasma leakage with or without bleeding, and we cannot, it's unpredictable, so monitoring is important. and timely management, repeated clinical examination for those with warning signs. The WHO clinical guidelines are extremely helpful, and I request all to go through it. And we must have a low threshold of suspicion for dengue, for any fever, especially during the dengue season. Thank you so much.
Thank you, Dr. Dania, for your crisp, lucid, and a focused talk. Thank you so much for focusing on the WHO guidelines. I think the audience needs to know that these are one of the most robust evidence-based guidelines on dengue available. Well, way back in 2000, whenever we had diagnosed dengue, almost every child was hospitalized. The parents were shattered with the diagnosis. Overzealous treatment was the order of the day, and morbidity and mortality was pretty high. We have with us Dr. Vijay Evle, who will speak on office practice management of dengue, because nowadays most of the treatment is in office practice, and the challenges are to identify those patients who have criticality and also titrate treatment so that unnecessary treatment is not given. Over to Dr. Vijay Evle. Dr. Vijay, the screen is all yours.
Very good morning, my friend Dr. Sanjay, and all my colleagues and friends from the IAP Twin City branch. Is my screen visible and am I audible?
Yes, you are visible and audible.
Okay, fine. So I have been, thank you Dania for setting up the stage for a talk on dengue management. And as Dr. Sanjay said, I'm going to concentrate on management of dengue in office practice, not necessarily in the office, but in office practice. So I bring greetings on this Azadi Ka Amrit Mahotsav to all my colleagues. And let's look at how do I manage dengue fever in my office. The key to successful management of dengue fever is to have a very high index of suspicion. And if you look at the WHO manual, one of the best written handbook on management of dengue in nursing home level, there is a clear directive saying that suspect dengue in every acute febrile illness in the dengue endemic region. And you all know that dengue is highly endemic in our country. So unless you suspect, you would not be able to diagnose it in early stage. And once you diagnose dengue early, the treatment is very simple. Just monitoring and ensuring that there is adequate tissue perfusion. So that important is to suspect dengue, because there is a great deal of overlap in the clinical manifestation of dengue and other tropical infections that we very commonly see in our country, especially during monsoon, when other illnesses like flu-like illness, your malaria, your enteric fever, all come, together. Now, just to quickly recapitulate certain pathophysiological bases so that it becomes easy for us to understand the rationale of management. Here is the schematic presentation where what happens when you are infected with one type of dengue virus, you develop neutralizing antibodies and the virus is circulated. When such an individual is secondarily infected or gets dengue infection second type with another type of virus, the antibodies which are formed because of prior sensitization don't lock properly. They are heterologous antibodies. And this virus antibody complex is picked up by the mononuclear cells of our body. And this is what leads to what is known as antibody enhancement of the disease, which is characterized by two important features, capillary leak and abnormal hemostasis. So if you understand this, then it becomes very, very easy to manage dengue fever. So capillary leak and abnormal hemostasis is characteristic of a second dengue infection. So what are the clinical implications? That you need to have a very high index of suspicion and should be on lookout for these two features in a patient where you suspect dengue. But mind you, friends, out of 100 second infections, only 5 to 8 would progress to your classical dengue hemorrhagic fever. So fortunately, by God's grace, even almost as many as 95 out of 100, they escape. Dengue is a continuum, and not that every child goes through that febrile phase, critical phase, and recovery phase. Some may just skip the critical phase. Not all secondary infection progress to severe DHF. Capillary leak lasts for about, and the capillary leak, which occurs as because of the cytokine storm, by and large, does not last beyond 48 hours. And this leak would vary from patient to patient. There's a differing, degree of severity of leak. So some patients just don't leak. Some leak so much so that they end up in shock. And by God's grace, again, majority of them would leak, and the management is not very, very difficult. Now, this is a 1-year-old boy, fever with ARI symptoms. A second case, 10-year-old girl, fever of 3 days, anorexia, backache, flushing, macular rash, and the spleen is just palpable. So are these dengue cases? I would say yes, certainly. Undifferentiated fever is the very common presentation of first or primary dengue infection in very young children, where they would exactly look like any other viral illness. We don't end up making a diagnosis of dengue in these children, but these are the children, when they get secondarily infected, they land up with your classical dengue hemorrhage fever. And we wonder, we hardly get history of prior dengue in these patients. So patients at presentation, they would present like secondary dengue, and we have no clue whatsoever to the past infection. And here is the answer, because most of them would present as undiagnosed, undifferentiated fever in early childhood. And this classical presentation, which is seen in older children and adolescents or adults of primary dengue, is characterized by high fever, which would last from 2 to 7 days, backache. Many of them have retroorbital pain. There is flushing, and your organomegaly may be there. And these children may or may not have thrombocytopenia. Typically, remember, in an adolescent girl who has attained menarche, she may complain of excess flow if she is in menses. Now, look at this child. This is a 6-year-old boy who, weighing 20 kg, has fever of 3 days, has been occasionally vomiting. And like in Mumbai, I'm sure in Hyderabad also, you must be seeing a lot of cases of other tropical infections like flu and malaria. As Sanjay said, malaria is is almost disappeared, but we have started seeing cases of malaria and then enteric fever. So these are the differentials that one would entertain. This child underwent a CBC on day 3 of illness, and this is what the picture showed, with marginally low platelet count of 1.6 lakh normal, lowish normal count and 50% neutrophils. As ad nauseum, let me repeat that you must suspect dengue in all such cases with acute febrile illness. Now, next day, this child comes with vomiting, abdominal pain, and passing less urine. And you repeat his CBC, and there is hemoconcentration. The platelets have dipped further. And as Dania said, that this child probably has developed now warning sign, has gone into the critical phase, and as evident by the capillary leak. But if you look at this child and the case that I showed you a minute ago, 10-year-old girl, fever of 3 days, anorexia, backache, flushing, macular rash, both have had fever of acute febrile illness, and one progressed to developing a secondary dengue hemorrhage fever, whereas the other girl just came out just by simple paracetamol and adequate fluid and rest. So the point that I'm trying to make again is, at presentation, it is extremely difficult to differentiate a primary infection from secondary infection. So one must look at every dengue case that you see as a potential case of secondary dengue fever, which can progress to capillary leak and complications. Because your dengue diagnostic test, your NS1 or dengue serology, though it may aid in diagnosis or confirming your clinical diagnosis, does not differentiate primary from secondary. And having realized this, WHO redefined the classification of dengue as dengue without warning sign, dengue with warning sign, and severe dengue. So this has been covered by Dania, that probable dengue is one who is living in an endemic area who has fever of 2 to 7 days duration with the manifestations which are enlisted here, and one who progresses and develops warning sign would have this classical, because let me repeat this warning sign: persistent vomiting, epigastric pain, evidence of fluid accumulation in the form of these children become slightly tachypneic as fluid starts accumulating in the pleural space. There could be mucosal bleed, restlessness, lethargy because of tissue under perfusion, hepatomegaly, and if you look at the investigations, you have marginally rising hematocrit and falling platelet. And then you have severe dengue. Either of them can progress to severe dengue. And Dania mentioned that there could be 3 manifestations: severe plasma leakage, severe bleeding, and severe organ dysfunction. Now, this child, 10-year, feeling weak, no appetite, prefers to lie down. This child was brought to our OPD, and waiting in the OPD, the parents want to see the doctor early, but they are at the same time comfortable since the child is preferring to lie down and is lying on the bench in the waiting area. You see the child, and the child is afebrile but is tachycardic, and not on interrogation you realize that the child has not passed urine since 12 hours. And parents have been attributing this to post-viral exhaustion. ये होता है viral infection when he is gone weak. But friends, you must remember that this is a child who perhaps has entered the critical phase, where, as Danya mentioned, sometimes the temperature can go subnormal and the children feel so exhausted with out of tissue perfusion. The typical history would be child had fever for 3 to 4 days and now he is just refusing to get up from the bed. He has to be carried to the wash basin for brushing. He refuses to come to dining table for food, and in the clinic he prefers to lie down. So this is something that you need to pick up early and institute adequate fluid therapy. And if you understand this diagram, which again Danya tried to explain to you, this is the place where this is the time this child has presented, and it is extremely important to examine, take history in detail, and ask for urine output and go further. Now, coming back to our first patient, that 6-year-old boy who was suspected to have dengue. So the next question would obviously be, what test do you run for dengue? Now, dengue fever has a febrile phase, which will last for about 3 to 4 days, where you have a lot of viremia, and antigen comes from the viruses. So you perform your NS1 antigen, which is extremely sensitive test, sensitive as 90% in primary infection, 70% in secondary infection. It is almost 100% specific for dengue. You make a diagnosis, you are on alert, your antenna are up, and you look for warning sign in such a child. It becomes easy to counsel the parents also, without scaring them, of course, because many parents with NS1 positive would want their children to be admitted. Let's not do that. Let's not overwhelm the healthcare system. This is a common problem in public health hospital, that every child is admitted, and those who come in secondary, in the critical phase, very often they don't get bed. Then, after going through the critical phase, the recovery begins, and in this recovery phase, on day 6 of fever, your antibodies become detectable. They may start appearing as early as day 4, but most of the kids would not, pick it up at on day 4 or day 5. So ideal is to do beyond day 6 or on day 6 of illness, where you would ask for IgG or IgM. Remember, it is the IgM which is the first response to any infection, followed by an IgG. When you have a primary infection, there is an IgM followed by IgG, a small peak. When you have a secondary infection, you have an anamnestic response and a very high peak of IgG. And these children also have a very small peak of IgM, which most of the kids do not pick up. Now, one must remember that you must get this test done on WHO standardized scale. ELISA would be ideal, but very often most of the practice would rely on rapid test. Now, there are qualitative tests available where you have positivity or negativity. Dengue IgG, the positivity of IgG in such kids is at a very high level of IgG levels. So meaning thereby, if you have a positive IgG qualitative test, it means that the IgG levels are very high, and that indirectly tells you that this is a secondary infection. So this is how one would go about testing the dengue, NS1 in first 3-4 days, and antibodies beyond day 5 of illness. However, very often the patients will present somewhere here where neither is NS1 positive nor your antibodies detectable. So what comes to your rescue, your clinical assessment and your CBC, where you look at platelet count and the hematocrit. As Dania explained before, there is a dip in platelet count and a parallel increase in hematocrit. And this is what would help you making a diagnosis of dengue fever, because children would present when they become in the early critical phase, and there none of the serological tests would be positive. So dengue serology is best to send all in single sample, because very often in practice, it becomes difficult to know the exact day of illness, the first day of illness, because your sensitivity vary from depending on the duration of illness. ELISA is more sensitive, ideal to a dengue serial CBC. NS1 is a specific test with which is highly sensitive in the first 3 to 4 days. It does not predict severity and it does not differentiate primary from secondary infection. IgM and or IgG detectable post 5 days of illness, and repeated clinical assessment and serial CBC is extremely important. So when a patient comes to you in office, you must take history in detail, warn this patient of warning signs, and educate the patient on warning signs.
Vijay, you have 5 minutes time.
Yeah, when you talk about warning sign, you must tell them to keep a watch on the child's temperature record, his activity, and urine output. In urine output, you must be a little explicit. You must ask the child to parents not only to look at the number of times that the child passes urine, but the color and quantity as well. Because a child passing a few drops of concentrated urine every 5-6 hours is not adequate. So this has to be borne in mind. So this child underwent NS1, it was positive. So this is dengue. So we know that febrile phase is viremic phase and there is no specific treatment. What is important to understand is it is the treatment during the critical phase where you need to sustain tissue perfusion. And sometimes patients come to you with a diagnosis of dengue and they have received tons of IV fluids and they are fluid overloaded. And this heralds recovery. Unfortunately, there used to be a lot of death because of pulmonary edema and fluid overload in the past. And we may have to use basics. I'm sure my intensivist colleague would cover this, but this is extremely important. So access to medical care and early detection of progression is extremely important in successful management of dengue and to lower the case fatality. Access to proper medical care was a challenge in COVID pandemic era. However, fortunately, we are out of it now, almost out of it. And as Dania said, there could be overlapping clinical features. A child may show COVID positivity, both the PCR as well as the antibody positivity, and may also have dengue. And there is a bit of similarity in the underlying pathophysiology when it comes to a leaky dengue. And we'll talk about it later, or maybe my intensivist colleague would cover it. So should you admit such child? As I said, please do not admit every child. When do you admit? If you are unable to manage hydration of such a child at home, if there are comorbid conditions, or if it is an infant, or if there are warning signs present, or it is severe case of dengue, you would admit. Otherwise, it is not at all difficult to manage these patients in office on outdoor basis. What do you advise? Adequate rest, adequate fluid, which could be in the form of ORS, fruit juices, your regular normal diet, and paracetamol. This is the key. Good 15 mg per kg per dose of paracetamol. Avoid NSAIDs because they have a tendency of bleeding. And this is what is classically described by WHO as Group A kind of patients who we manage in office, who have no warning signs, who are able to tolerate fluids orally, and you monitor urine output at least every 6 hours and advise them to take adequate rest, adequate fluid, and paracetamol. Other tests will be especially the liver enzymes. We know that all tropical infections will have minor elevation. SGOT would rise ahead of SGPT. Blood cultures would not ask unless you suspect enteric in the case of acute febrile illness. Vidal, let me not talk about it. X-ray test is also not required. Sonography is something which, if it is available, helps you in detecting the early, leak. Unfortunately, with the stringent PCP-NDT Act, we do not have portable sonography machine in every nursing home. But I had been to Sri Lanka, where in the dengue management ward, they had monitor attached to every bed, a portable sonography machine, and a dengue triple card test. And every staff nurse and every resident doctor is trained in just putting a probe on the right side of the chest and recognize early leakage in the pleural space. And they have a centrifuge in the ward, and they have successfully brought down the dengue fatality to less than 1%. So crux of management is again early detection of beginning of a leak, meticulous monitoring, and accurate titration of fluid. You must explain to the parents the warning signs. And this child was sent home. Next day he comes back vomiting. We know that he's now entered the critical phase, and his platelet counts have dipped to below 1 lakh. So this is your Group B child where you have warning signs. And as I said before, infants, diabetic, or children with comorbidity should be treated as group B and should be advised admission, or the child is unable to manage hydration at home. You can still manage these children if they are able to tolerate orally well with oral fluids, not necessarily IV fluid. But once admitted, it is better to secure an IV line. It is better to have blood grouping done upfront, because a child may require colloids, and very often colloids may interfere with blood grouping. And when child starts bleeding, it can be really tough. So this is your group B patient, where you either manage orally or IV fluid, depending on if the child is able to tolerate or not. So this is so beautifully described in the WHO manual or handbook on management of dengue, group A, group B, and group C. And group C is obviously severe management, which will be dealt with by the intensivist, where a child could come in compensated or hypotensive shock. And remember, dengue is a continuum, not that every child goes through all these phases, not that every child has a similar course, and it would vary depending on it. So this child got admitted. Obviously, I would not leave any platform to talk about antibiotic. Please do not administer antibiotic. It's a pure viral illness. Low platelet count is something that worries parents. Every parent would demand admission. Avoid that. Low platelet can occur in dengue fever, in febrile phase, classically occurs in critical phase, and it is around 1 lakh that it indicates that the child has started entering the leaky phase. Look at this girl, 5-year-old girl brought by worried parents for itching all over and low platelet count. Had fever for 3 days, and parents are worried. They're worried of this low platelet count, and they want the child to be admitted. You do CBC and it shows platelet of 87,000. Remember, an itchy child who is afebrile, who has had fever for 3 to 4 days, and the illness is about 5 to 6 days, it heralds a recovery. And very often these children are bradycardic. You just need to counsel the parents, because some children may take a little longer to recover of thrombocytopenia. A good test which is handy is to do immature platelet fraction. And large platelets indicate that the platelets are now being produced by the bone marrow and are being thrown into circulation. 9-year-old boy recovering of dengue illness, persistent low platelet count 5 days post-recovery. And this child turned out to be dengue-induced ITP. So dengue is another viral infection which can have persistent low platelet count, which can be a normal phenomenon in some children, who may take a little longer than others to recover, or it could indicate other illnesses. One must know, not common. One must keep in mind a possibility of dengue-induced complication like ITP. So reasons for a persistent low platelet count in a patient of dengue is some may have a gradual recovery, may take a little longer than others, dengue-induced ITP, and secondary HLH. Secondary HLH, of course, the child would look sick and there will be other parameters to be looked at. And finally, I still remember this case thanks to my friend Dr. Prakash Vaidya from Mulund, who had presented this in one of the seminars, where the patient would show very low count persistently. Otherwise, the patient recovered pretty well and there's nothing to. Finally, what they did, they collected blood in heparin and the platelet counts turned out. So this child had antibodies to EDTA, and all the EDTA samples would show spurious thrombocytopenia. So friends, this is how one would manage dengue in office. And when it comes to fluid therapy, I'll just quickly, wind up with this one slide where, way back in 2006, we used to be very aggressive would infuse liters and liters of fluid in dengue patients and look at, aim at maintaining a positive balance. And in the bargain, what used to happen, there used to be tremendous degree of fluid overload. Many children ended up with pulmonary edema requiring Lasix. Some children lost their lives. And having realized this, WHO revised the dengue management and to avoid this complication death. Now what is recommended by WHO is you must transfuse or infuse enough to maintain tissue perfusion. You aim at an urine output which is above the oliguria level, that is 0.5 to 1 ml per kg per hour. And this is what the WHO 2009 handbook would recommend. And this prevented multiple complications and tissue injury. This does not come in office management. However, one must remember that less is more now, and you aim at a urine output of 0.5 to 1 ml per kg. You need not give IV fluid to every patient. If the child is able to take orally, even oral fluids are adequate so long as you monitor this child for urine output and other vitals. Or you may start with your maintenance fluid like holiday cigar formula, 4 ml per kg, and then you up or down. And the moment you reach 7 ml per kg for a child to maintain hematocrit, you must think of introducing colloid. Now, a big question that very often is asked is how often do you repeat CBC and hematocrit? Well, in office practice, day one of acute febrile illness, doing a CBC does not really reward you much, does not tell you much. You usually do it on day 3 or so. And having diagnosed or suspected dengue, you must repeat CBC and hematocrit just on day 3 or day 4, or when the fever breaks. And then depending on the value, you may advise a repeat of CBC. Doing CBC every day just because the platelets are dipping does not really make much of sense. You ask the parents to maintain good temperature record and urine output. If the child is throwing out adequate urine and if his clinical parameters are stable, you did not ask for CBC every day. You may do it every other day. And we know that critical phase by and large does not last more than 48 hours. So CBC 2 days later, just to ensure that the things are good enough or are not deteriorating, is good enough. And secondly, not to forget that the WBC count and the platelets, they go hand parallelly, they move parallelly, and at recovery they both start coming up. So this is how you would manage. I would not talk about colloids and other fluid management. I think I will, Sanjay, this is again a good diagram to show you that in leaky phase, the more you infuse, the more it leaks and it adds to the complications and it adversely impacts the outcome. Now, Sanjay, I think I would stop here. And final word before I end up is ferritin. Ferritin is something which is very often asked by many pediatricians. Remember, ferritin comes from your mononuclear cells, macrophage and monocytes, and it also comes from hepatocytes. So dengue virus typically, replicates in all these tissues, all these cells, and you have hyperferritinemia. And hyperferritinemia does not necessarily mean HLH or a severe form of infection. It is very common occurrence in dengue fever. Unless you have accompanying, evidence of HLH, don't jump to a conclusion of HLH based only on high ferritin levels. Very often, children are over-treated for hyperferritinemia. I think in the interest of time and the program, I would stop here. And thank you once again, Sanjay, for the opportunity. And it was a wonderful opportunity to interact with. Thank you.
Thank you, Vijay. I'm sure you are an encyclopedia on dengue, and given opportunity, you would have dealt almost all topics solo. Thank you so much, Vijay, and especially with the nice case scenarios which you have presented. It was very focused and an excellent presentation. In dengue fever, the challenge is when to hospitalize. We have partly covered it, but when to hospitalize and when to shift from the hospital ward to the ICU is a challenge. What to monitor in the ICU is another challenge. Which fluid to give and how much to give. You saw the lovely diagram Vijay had put across. Role of colloids. We did a lot of mistake or error by giving blood and blood products. Role of vasopressors. When to suspect complications. Whether to give antibiotics, if so, when. What is the role of steroids, immunoglobulins? Vijay partly touched on HLH. We have Dr. Anupama to speak on this. Dr. Anupama, it's all yours. The screen is yours. Your attention to Dr. Anupama. Please unmute yourself, Dr. Anupama. Please,
Yeah. My screen is visible, sir?
No, Dr. Anupama, your screen is not visible. Anybody from the IT can help out? Dr. Bhaskar?
Sir, please go for a share screen, madam.
Yeah.
On your desktop, Please share screen. Yeah.
Is it visible now?
Yeah. It is visible and you are audible.
Go for full screen, madam. With the
Yeah.
down.
Dr. Anupama, you have 20 minutes.
Yes, sir. Yes, sir. Thank you, sir. Thank you very much. I would like to thank IAP for giving me this opportunity to present this topic on dengue in ICU. The topic says dengue in ICU, make it simple, but I would say it is not simple. So dengue is still a global disease burden. I think 2019 was the year where we have seen the largest reported cases, and in literature also it has been mentioned that 2019 was the year where there has been a largest reported cases of dengue. Still a global disease burden, no specific antiviral, no vaccine. Most eventually recover in 5 to 7 days. 10% develop severe dengue in the form of intravascular leakage, organ impairment, and severe hemorrhage. Looking at the pathogenesis of dengue fever, it predominantly affects the endothelial cells, the liver, the tissue macrophages, and the bone marrow, causing endotheliopathy, endothelial dysfunction, and plasma leakage. It replicates in the liver cells, releasing various toxic products into the blood, and thereby causing disorders in the coagulation and consumption of platelet. Excessive activation of the macrophages causes hyperinflammation and may predispose to cytokine storm and suppression, and it replicates as well as in the bone marrow cells, causing suppression of the hematopoietic system. According to the WHO classification of dengue, when we say severe dengue, it means that there are signs of severe plasma leakage, severe hemorrhage, or severe organ impairment. Severe plasma leakage leading to dengue shock syndrome, or fluid accumulation leading to severe distress or abdominal compartment syndrome. So looking at the clinical course of dengue, dengue is a systemic disease and it is a dynamic disease. It has got a quite demarcated 3 clinical phases: the febrile phase, the critical phase, and the recovery phase. So the critical phase is generally heralded by a few lab markers like rise in the hematocrit, fall in the platelet count, and leukopenia. And sometimes if you do an ultrasound, you will see a thickened gallbladder and pleural effusion and ascites. It is during the critical phase that we see children with severe dengue with shock, bleeding, and organ impairment. There are different clinical phenotypes of severe dengue which can get presented and can be shifted to ICU. Children with severe plasma leakage, organ impairment, bleeding, children who present with multi-organ involvement due to cytokine storm, or children with predominant cardiac dysfunction, dengue myocarditis, neurological complications like ANE, Guillain-Barré syndrome, transverse myelitis, children who present with macrophage activation syndrome and HLH, and co-infections of dengue with malaria or hemolytic uremic syndrome. And if you ask, the list keeps going on. Now, coming to the most common reason why children get shifted to ICU is because of dengue shock syndrome. In dengue shock syndrome, there is leakage of plasma, there is hemoconcentration, there is depletion of the intravascular volume, and there could be a coexistent hemorrhage or myocardial dysfunction and vasculopathy. So what are the principles of management when we manage children with dengue shock syndrome? Appropriate and timely fluid resuscitation. It is always fluid. Preventing and management of bleeding. Prolonged shock, hypoxia, and acidosis are the major risk factors for bleeding in dengue, not thrombocytopenia or leakage coagulation. Having a better monitoring in the form of intra-arterial blood pressure, if possible, doing a bladder pressure monitoring, a strict urine output monitoring and input-output chart is something which can be done in every hospital, in every setting, and it's the cheapest way of monitoring these children. And if the facility and the feasibility is there, having a bedside ultrasound. And then serial lab monitoring in the form of hematocrit, electrolytes, identifying hypocalcemia and hypoglycemia. And during the critical phase of plasma leakage of 24 to 48 hours, understanding the dynamicity of the disease and the need for continuous monitoring. So if you look at the whole diagram, the role of vasopressor and inotrope is very negligible. And the most important role is appropriate timely fluid resuscitation, looking for ongoing hemorrhage and adequate monitoring. So as this going through the flow chart as advocated with the WHO and explained nicely by Dr. Vijay Yavale sir. Now, when we see a child with a compensated shock where the blood pressures are maintained, but there are signs of poor perfusion, the initial fluid bolus would be an isotonic crystalloid at a 10 to 20 ml per kilo over a period of 1 hour. And at the end of 1 hour, we need to assess for improvement in the form of heart rate, the blood pressure, the perfusion, and the pulse pressure. Dengue is a hypovolemic shock. In this, the shock is vasoconstricted. The diastolic blood pressures are very high. As a reason, the pulse pressures are also very narrow. This phase of plasma leakage generally lasts for only 24 to 48 hours in respect to dengue. So even after giving a 10 to 20 ml per kilo over a period of 1 hour, if the shock has not improved and the hematocrit is rising, consider one more crystalloid or a colloid bolus administered over a period of 1 hour. As the shock is compensated and the blood pressures are maintained, there are only signs of poor perfusion, narrow pulse pressure, and tachycardia. But if the shock is associated with a fall of hematocrit, always think of overt bleeding and try to arrange for blood transfusion in children with compensated shock. When we see children with hypotensive shock, stabilize the airway, provide high flow oxygen, and here the fluid administration of the bolus should be given over a period of 50 to 20 minutes and try to obtain a baseline hematocrit and catheterize the child. And the same similar principles are followed, but here concentration of colloid, the second fluid bolus in case of hypotension should be concentration should be given to a colloid. Colloid boluses could be dextran, gelatin, starch, or 5% albumin. In a subsequent slide, I would discuss about what would be the choice of a colloid, but over the years, the choice of colloid has been more towards 5% albumin, and by the second bolus, there should be an early concentration of a colloid when we are seeing children with dengue, with hypotensive shock, where the systolic blood pressure is less than the 5th centile. And consider invasive arterial blood pressure monitoring in these children, as well as a bladder pressure monitoring if the fluid resuscitation and the need is more than 30 ml per kilo. The commonest cause of uncorrected shock or recurrence of shock is inadequate replacement of plasma losses and occult hemorrhage. So what monitoring do we need to do during this critical phase of plasma leakage? Hematocrit should be monitored every 2nd hourly to 4th hourly in the first 6 to 12 hours of resuscitation. And once the child shock is corrected, to continue for the ongoing maintenance fluid requirement, monitor your hematocrits at least 6th hourly to 8th hourly. Target a minimal acceptable urine output of 0.5 to 1 ml per kilo per hour, the cheapest and the best available monitor, and ensure that your nursing team does a strict input-output monitoring in these children. If the urine output is more than 1.5 ml per kilo per hour, think of hyperglycemia and prompt you to reduce the maintenance fluid. And the endpoint for rapid fluid bolus resuscitation is improvement in the systolic blood pressure, widening of the pulse pressure, improvement of the perfusion, urine output, and normalization of the hematocrit. Now, between crystalloids and colloids in fluid resuscitation, a large number of studies have been done, especially in Vietnamese children, where they have studied between normal saline rigor lactate versus gelatin and dextran and starch. Some studies showed that colloids were better in restoring the hemodynamic stability faster. Certain studies did not show any clear advantage, but the problem over the years with the better understanding of management of shock in children, be it dengue shock or septic shock, people have realized that using gelatin, dextran, or starch are associated with various adverse effects on their coagulation profile, allergic potential, and other significant side effects like renal failure. So nowadays, the trend is more towards using 5% albumin as a colloid, but the only disadvantage of using a 5% albumin is the cost involved when albumin is chosen as the colloid for resuscitation in dengue shock. Apart from the most important component, other component is recognition and management of hemorrhage when we see these children with shock. If the hematocrit is lower than the degree of the shock and the shock is not resolved even after 40 to 60 ml per kg of resuscitation with crystalloid or colloid, think of an occult hemorrhage. The clinical features initially will be very subtle. The child will have tachycardia, child will have abdominal pain, child will be in distress, agitated, there will be worsening acidosis, and instead of leukopenia, you would see a stress-induced leukocytosis, which should alert us thinking about an occult hemorrhage when we are managing these children with dengue shock syndrome. Hemorrhage and frank hypertension is a late presentation, and in this situation, urgent blood transfusion is needed. Bleeding ongoing despite blood transfusion, then only consider giving plasma or platelet transfusion, and prophylactic platelet transfusion to prevent bleeding or to prevent hemorrhage is a big no in the management of children with dengue shock syndrome. Despite appropriate fluid resuscitation, looking for ongoing hemorrhage, certain children still can tend to have unresolved shock or persistent shock during the course of illness. Whenever there's persistent shock or unresolved shock, always again think and check whether is there still an uncorrected hypovolemia or is there an occult bleeding or hemorrhage which has been missed. Or consider doing a 2D echo to look for a myocardial dysfunction. Many times these children, because of uncorrected hypovolemia and high systemic vascular resistance, there could be a coronary ischemia as a maladaptive phenomenon causing myocardial dysfunction, and this myocardial dysfunction can be one of the reasons for the persistent shock. In certain situations, many times there's a tendency for people to use inotropes or vasopressors, and in the using of inotropes or vasopressors with uncorrected hypovolemia will further worsen the myocardial dysfunction and will further worsen the shock and the clinical situation. Or is there an abdominal compartment syndrome, a large volume ascites, a gut which is edematic and ischemic can also worsen the shock and organ failure. So whenever you see a child with a persistent shock despite appropriate fluid resuscitation, do a bedside 2D echo, rule out is there a coexistent myocardial dysfunction, is the unnecessary use of inotropes or vasopressors going on, or measure the child's bladder pressure and see whether the child is developing abdominal compartment syndrome. Intra-abdominal pressure more than 10 is called high and associated with organ dysfunction is called abdominal compartment syndrome. So what is the algorithm you would follow if you see children with severe dengue with refractory shock or those who present late to your unit? Stabilize their airway breathing circulation. Give them 10 to 30 ml per kilo of crystalloid followed an early colloid from the second fluid bolus administered over a period of 50 to 30 minutes. Correct their hypoglycemia and hypocalcemia. Monitor the urine output hourly and perfusion. Do invasive arterial blood pressure monitoring and monitor the hematocrit every second to fourth hourly. If the shock persists despite you resuscitating with 40 to 60 ml per kilo, think of these 5 reasons. Occult bleed. Is there a coexistent bacterial infection or malaria in an endemic region? Consider starting IV, broad spectrum IV antibiotics. Do a 2D echo to look for myocardial dysfunction. Measure the bladder pressure. If there is an abdominal compartment syndrome where the intra-abdominal pressure is more than 10 associated with oliguria, go ahead and plan abdominal paracentesis and drain the fluid cautiously. And despite that, if the shock is persistent, then there could be a widespread hypoxic ischemic injury causing a terminal vasoplegic shock. And none of these measures would help in this such clinical scenario. Children with severe dengue, refractory shock, and those who present late and eventually develop respiratory distress and would need respiratory support in the form of mechanical ventilation. So in these children, mechanical ventilation is a high-risk intubation and it needs to be done cautiously. These children would need invasive lines and these lines need to be placed under ultrasound guidance. Once the invasive lines and ultrasound guidance has been placed, and if the CVP trend is acceptable, the hematocrit is normal, and still the shock is persistent, then only at this last point you would consider inotropes or vasopressors or inodilators in these children. If the systolic blood pressure is less than the 5th centile, you can consider adrenaline. If the hypovolemia is corrected, there is no occult hemorrhage, and the CVP trend is acceptable and the hematocrit is normal. If the systolic blood pressure is normal and the child is in shock with signs of poor perfusion, you can consider dobutamine, or if the intra-abdominal pressure is very high, you can perform abdominal paracentesis. All ICU interventions, especially in children with severe dengue, need to be done cautiously because even the interventions can tip the balance, can worsen the clinical scenario of the child. So placement of OG tube is better than an NG tube, especially in a sick dengue child with bleeding, risk of bleeding. Central lines need to be placed cautiously under ultrasound guidance by the senior person in the unit. Intubation is always a high-risk intubation because there could be a rapid decompensation in sick dengue children in dengue shock syndrome with ongoing hemorrhage, and the child can go into a cardiorespiratory arrest. So avoid drugs like benzodiazepines and use ketamine. Consider apneic pre-oxygenation. During the peri-intubation period, you can give the child non-invasive ventilation or CPAP and start vasoactive infusion like low-dose adrenaline at 0.05 mics per kg per minute during the peri-intubation period. And rapid drainage of large volume pleural or ascitic fluid collections, especially during the critical phase of plasma leakage, can also cause sudden worsening of the hemodynamic status and catastrophic hemorrhage. So all ICU interventions, even from placing a simple NG tube to intubation, need to be done cautiously in children with severe dengue in dengue shock syndrome. This is a study published by Dr. Suchitra Anjit et al. In ISCM journal, where they found out that certain targeted interventions does decrease the risk or does decrease the mortality in children with severe dengue by using restrictive resuscitation and using colloids. If the need for crystalloid resuscitation need is more than 30 ml per kilo in the first 3 hours, they have considered using albumin 1 gram per kg over 4 to 6 hours. And they have included this albumin also in their hourly fluid rates. Then measuring intra-abdominal pressure or bladder pressure, if the volume resuscitation is more than 30 ml per kilo, you can measure bladder pressure easily through the Foley's catheter by using an arterial transducer, zeroing at the mid-axillary line. If the bladder pressure is more than 10, they considered measures like decreasing the fluid, overall maintenance fluid, considering the diuretic if the plasma leakage is stopped, doing a gastrointestinal decompression. If the bladder pressure is more than 10 and associated with organ dysfunction, like liver dysfunction or decreased urine output or worsening high cirrhosis, they've considered placing a pigtail catheter in the abdomen and doing a cautious abdominal paracentesis. Providing respiratory support in children with severe respiratory distress and respiratory failure, there was a preference for non-invasive ventilation if the child's sensorium was normal. If the child's sensorium was not normal and shock was worsening and child was in severe respiratory distress or respiratory failure, they considered intubation by following the high-risk intubation management protocol, where they considered apneic pre-oxygenation as well as apneic peri-intubation period, NIV, and peri-intubation period use of inotropes. Preventing major bleeds and using tranexamic acid infusion, considering whole blood versus blood products, and considering fluid removal techniques in children with fluid overload state, like administering diuretics, doing PD. But if the child has got an established acute renal injury and if the child has got diuretic resistive fluid overload, then considering SLED or CRRT. By following all these targeted interventions, they have realized that between the two groups, the mortality difference is so significant that the p-value was less than 0.008, and these interventions can be doable and can be doable in most of the critical care units. Now, coming
Dr. Anupama, you have 5 minutes.
Okay, sir. So coming to the fluid overload state in the dengue. So the fluid overload state in the dengue can be due to plasma leakage. It can be due to infusion of it is because of large volume resuscitation or overzealous administration of blood products, or not decreasing fluids when there's cessation of plasma leakage or use of hypotonic fluids. And this will cause raise in the intra-abdominal pressure, worsen the shock, cause oliguria, and it will predispose sometimes to infuse more fluids, thereby causing abdominal compartment syndrome, and thereby that itself further predisposes to worsening the shock and organ dysfunction. So proactively measuring the intra-abdominal pressure in severe dengue is recommended, especially when the resuscitation of fluid or the requirement of fluid resuscitation is more than 20 to 30 ml per kilo. So I'll just skip the case for the want of time. This is the second case. This is a case which many of us face and also worry when we see such children with dengue. 5-year-old child presented with high-grade fever for 2 days, poor oral intake and vomiting. Child was admitted in the ward, received fluids at 3 ml per kilo per hour. Dengue NS1 antigen was positive. He had to be shifted to ICU within 24 hours in view of dengue shock syndrome. So in the ICU, invasive hemodynamic monitoring was started. His fluids were titrated as per the PCV and the hemodynamic variables. In the next 18 hours, he was resuscitated with 30 ml per kilo of normal saline and 20 ml per kilo of 5% albumin. He also was administered an immunoglobulin in view of extreme hyperferritinemia. Now, if you look at the lab parameters of the child, this child had extreme hyperferritinemia of the ferritin more than around 55,000, high lactate, and a deranged coagulation profile with platelet count of 1 lakh. Subsequently, between day 2 to day 3, this child worsened, had to be intubated in view of worsening shock and encephalopathy. Invasive lines were placed, and the 2D echo showed a decreased myocardial function. And once the fluid leakage had stopped, the hemodynamics had stabilized, but the child ended up needing an inotrope of adrenaline of 0.05 mics per kg per minute. The child also developed abdominal compartment syndrome, and the intra-abdominal measures were persistently more than 15, for which peritoneal drain has been placed. Subsequently, on day 4, if you see at the labs of the child continued to have elevated procalcitonin, elevated ferritin, high SGOT, SGPT, and a deranged coagulation profile. There is a worsening in the oxygenation status of the child and increase in the inotropic requirement. So this is one of the few dreaded scenarios which we see in children with coming with dengue into the hospital, developing dengue shock syndrome, predisposing to multi-organ dysfunction and cytokine storms. So what could be the reason for these children with severe dengue to go into multi-organ dysfunction syndrome and cytokine storm? So there could be multiple, the pathophysiology could be different, but ultimately all of these children end up having what we call a cytokine storm. Either the child can have a tendency to have a familial HLH with a viral insult, or the child has developed a secondary HLH or a macrophage activation syndrome, or the child could have a coexistent bacterial sepsis and hyperferritinemia and a multi-organ failure. So these clinical phenotypes can be identified with these clinical pictures. These children tend to have persistent fever, persistent organ dysfunction, persistent cytopenias. Plasma leakage is also persistent in them beyond the 24 to 48 hours. They have extreme hyperferritinemia where the ferritin values are more than 10,000, ongoing bleeding. And pathophysiologically, these children have reduced NK cells and CD8 T cells to lyse the infected macrophages. And this augments the viral replication release of various pro-inflammatory cytokines, causing cytokine storm, organ damage. So looking at what happens when the dengue virus infects the body, once the dengue virus is injected into the skin, it is taken by the dendritic cell and the Langerhans cells. The NK cells and the macrophages are recruited at the site, and these NK cells and macrophages cause an interaction between the T cells and the B cells, releasing a various inflammatory mediators, and sometimes there's a gush of cytokines causing a cytokine storm in these children. So there's always a battle between the virus and the immune system. With a prior exposure to dengue virus, because of antibody-dependent enhancement and original antigenic sin phenomenon, the disease process is more exaggerated and there's a cytokine storm. It also depends upon the host genetic factors, the virus serotype, the age, and previous immunity. We need to understand the NK cell pathobiology when we see certain children with dengue with multi-organ dysfunction with cytokine storm. So normally, if the child has got a predisposition for a familial HLH, in these children, the NK cells function is absent. They are not able to perform the cytolytic activity, and they cause excessive macrophage activation and excessive hyperferritinemia. But in children with sepsis or viral-induced macrophage activation syndrome, the number of NK cells are less, so that is why they are not able to control the macrophage activation. But in case of a rheumatological disorder, here the number is reduced. The numbers are not okay, but the function is slightly reduced. We need to understand the difference between a familial HLH in children, which is triggered by a viral insult, versus a child with dengue with a secondary HLH or a macrophage activation syndrome, because the therapeutics are different in both the pathophysiological states. This study was recently published with respect to ITSA, where they found out in adults, those with high inflammatory biomarkers like ferritin, triglycerides, soluble CD125, they found out that, and when they analyzed the NK cell function, they found out that all of them have got decreased NK cell function. And when they looked into the genetics, they also found out that they have some polymorphism in their NK cell cytolytic function genes. And this spectrum of people are more predisposed to cytokine storm, multi-organ dysfunction, and these children need, or these spectrum of dengue need immunomodulation. So it's very common nowadays that many of us do a test called ferritin and dengue. Many times we don't understand whether this ferritin is just an innocent bystander of uncontrolled inflammation or it is a mediator of immune dysregulation. So how do we understand it clinically? If the ferritin is associated with no organ impairment, no fever, no persistent cytopenias, so it is just an innocent bystander of uncontrolled inflammation. This phase of critical phase, once the critical phase gets better, the ferritin is going to get down or improve by itself. But if the excessive hyperferritinemia is associated with the features of cytokine storm, where there is fever, persistent cytopenia, organ impairment, bleeding, then this ferritin is not an innocent bystander. It is a key mediator of immune dysregulation. Serum ferritin in dengue and its implications. It is produced by monocytes, macrophages, and hepatic cells. It's a pro-inflammatory cytokines, and iron also produce ferritin. In dengue, if there is a secondary infection, microbial translocation itself can promote ferritin production. Bleeding in dengue causes release of free hemoglobin, and free hemoglobin also stimulates the macrophages to produce high ferritin. So when you see a high ferritin, think of these following clinical reasons. Is there a high viral load? Is there a secondary bacterial infection? Is there a liver injury or an abdominal compartment syndrome? Is there an occult hemorrhage? Or there is a genetic predisposition to develop HLH? And excess ferritin production itself can interfere with the B cell maturation, causing decreased immunoglobulin production and thereby predisposing to the child to further infections. So these different clinical phenotypes of cytokine storm need to be differentiated in children with dengue predisposing to multi-organ dysfunction. Is it a familial HLH, a secondary HLH having a macrophage activation syndrome, or because of coexistent bacterial sepsis, there is hyperferritinemia and multi-organ dysfunction. Now, the question comes because when we see certain children, there is a difference of opinion between the rheumatologist as well as the hematologist and the ICU intensivist. Which immunomodulation to use? Is it dexamethasone? Is it etoposide? Is it steroid, anakinra, plasmapheresis, immunoglobulin? It all depends upon what predisposed to that cytokine storm, and also depends upon the underlying pathobiology. If the cytokine storm or multi-organ dysfunction is due to a familial HLH, where there's a genetic predisposition because of a viral infection, the child has developed a HLH, then drugs like etoposide and dexamethasone can be used because they decrease the interferon gamma production and the macrophage activation. But if it is because of sepsis or viral sepsis, the child is having a macrophage activation syndrome or a secondary HLH, we cannot use drugs like dexamethasone and etoposide because these drugs prevent recovery of NK cell. And here in these drugs, we consider therapies like to reduce the inflammation like methylprednisolone, immunoglobulin, plasma exchange, and sometimes anakinra, which has been with the advent of COVID. Anakinra is also being tried in few in dengue, and few ongoing studies are being there at the moment. So the therapeutic modalities depends upon differentiating between these conditions. If the child's age is less than 2 years and there is history of sibling death, and the child is presented with dengue, with multi-organ dysfunction, cytokine storm, always think of a possibility of a familial HLH in these children. But if this child, there is no history of sibling death, the age of the child is an older child, and the child is presenting with multi-organ dysfunction, you have ruled out a coexistent bacterial infection, think of a secondary HLH or a macrophage activation syndrome. And in these children, supportive ICU care is very important, organ supportive therapy is very important, identifying treating infections is very important, and then choosing immunomodulation in the form of steroids, IV immunoglobulin, sometimes extracorporeal heme absorption decrease, like cytosorb and plasma exchange. Sir, do we have time still?
You have overshot the time by
Okay,
10
sir.
minutes, Doctor. If
Yeah,
you can briefly summarize and
yes,
give some details.
yes, I'll just go down to the summary, sir. So dengue in ICU is in simple, appropriate and timely fluid resuscitation, understanding the dynamicity and emphasis of continuous monitoring during the leaky phase. Prophylactic blood products is a big no. Dengue shock is a hypovolemic shock. Septic shock is a distributive shock. Or if you see a narrow pulse pressure, a high diastolic blood pressure, and always think it is dengue shock, because many times when we receive children in shock during the dengue season, there's always a confusion. Is it a dengue shock or a septic shock? In dengue, the shock is predominantly, it is a hypovolemic shock with a narrow pulse pressure. Always consider fluids and early consideration of colloids. No major role for vasopressors or inotropes. If there is an uncorrected shock, think of ongoing plasma leakage, occult hemorrhage, myocardial dysfunction, co-infections, and abdominal compartment syndrome. Look for the spectrum of cytokine storm in these children with dengue who progress to develop multi-organ failure, where they have persistent fever, cytopenias, organ impairments, and extreme hyperferritinemia, where the ferritin levels will be more than 10,000. And always monitor the 5 P's in dengue, which is PCV, the pulse pressure, the blood pressure, intra-arterial blood pressure and intra-abdominal blood pressure, and the skin perfusion. Keep watching these 5 parameters and interpret the parameters appropriately in optimizing your fluid therapy in children with dengue shock syndrome. Thank you, sir.
Thank you, Dr. and Anupama. And I think the audience will all agree with me that with the advent of pediatric intensivists, the life of a pediatrician has become very simple, actually, because most of the challenges which we see in critical care are managed by intensivists. But thank you so much, Anupama. You have touched on when to shift to an ICU, what fluid to give, when to give colloids, which colloids to give, when to suspect complications. Thank you so much for your excellent lecture. Post-pandemic, the magic box of vaccines has opened up, and we have vaccines. You will see in future vaccines for various diseases, and I'm sure the world is eagerly waiting for a dengue vaccine. And I'm told that one of the dengue vaccines which is safe is in phase 3 trials. To tell us all about is Dr. Surendra Nath. Dr. Surendra, the screen is yours and it's your turn. Thank you so much. I request the audience to put their questions in the chat box, because we have covered most of the questions, and we'll try to shorten the panel discussion time because we have overshot time. So if the audience can post their questions in the chat box, I'll collect them question by question and put it to the panel for discussion. Thank you so much.
Good morning, sir. Can you hear me, sir?
Yeah, Surinder, your screen is visible.
My pranams to Dr. Sanjay sir, who is my guru. And not only that, our very close friend Vijayavale sir is there, who is the doyen of rational antibiotic practice. For dengue, it is more important, I think. So as far as the vaccines are concerned, we have seen tremendous development of vaccines, and we have seen the COVID vaccine, which has come in a period of 1 year. But unfortunately, dengue vaccine has been in the manufacturing phase almost 20 years. It took almost 20 years. And the present dengue vaccine, which has been released into the market in some of the countries, almost Sanofi must have spent about $2 billion. $2 billion was spent for the manufacturing of the dengue vaccine, and the research was there since almost 20 years. So we'll go back to the dengue vaccines which are available, and I'll try to talk about the vaccine which has been permitted to be used, followed by some of the vaccines in the pipeline, and what is the situation of dengue vaccine production as far as India is concerned. So coming to the immunity part, most of our speakers have dealt it very nicely. The mechanism of protective immunity against is not fully understood, really speaking. The major role of neutralizing antibodies, and sometimes there may be cytotoxic T-cell response may be there. And human antibodies against the Den virus are mostly targeted against the E protein and pre-membrane M protein. One serotype confers lasting protection as against the homotypic reinfection. That has already been told by Dr. Dania Dharmapalan. And Dr. Vijayavale sir clearly told that the protection against the heterotopic protection is only transient phenomena, maybe lasting for not more than 3 months. So the secondary heterotypic infection is associated with increased severity of the infection. And there is lack of adequate animal disease models as far as production of dengue vaccine is concerned. Not only that, dengue virus, there will be a poor growth in the cell cultures that hindered the development of the vaccines. So with this background, we know that secondary heterotopic infection is always associated with the severity of the infection. So we will see what are the vaccine technologies available for the dengue and what is going on in production of the dengue virus. So there are live attenuated vaccines are produced, and not only that, purified inactivated virus is also under process. And there are recombinant vaccines, and recombinant subunit vaccines are also under production. And they are trying to produce virus-like particles like HPV vaccine or hepatitis vaccine. And vaccines are using viral vectors, and the plasmid transmitted vaccines also are available now. So presently there are 3 types of vaccine candidates are there: live attenuated tetravalent vaccine. 3 companies are doing their trials. In fact, Sanofi Foster has successfully conducted the phase 3 trials, and it got the permission to be marketed. And now we have TV003, TV005, the live attenuated vaccine by the United States National Institute of Health. And another vaccine is tetravalent dengue vaccine by Takeda. It has almost completed the phase 3 trials, and they are applying for the marketing. Purified inactivated tetravalent vaccine is under production by the Walter Reed Army Institute of Research and GSK. Both put together, they are trying to manufacture the vaccine. And subunit protein vaccine, V180, is the one which is under the process. So coming to the live attenuated vaccine, we know that serial passage of virulent virus in the tissue culture has to be there. And via recombinant DNA technology that permits site-directed mutagenesis of the genome, virulent parent strain, which makes us attenuated virus. And not only that, chimerization with the flaviviruses has been done. These are the entire spectrum of vaccines which are under development. So you can see the phase marketing is Dengue Vaccine, that is Pasteur vaccine is available in some countries for the vaccination. And phase 3, TV033, TV005, and the Dengue vaccine are in the phase 3 trials, which have almost completed the phase 3 trial. So phase 1, we have inactivated vaccines and the Dengue ATE, and TVDV, that is the Naval Medical Research Center, is also in the phase 1. And some of the inactivated vaccines by the other companies also under the process. Not only that, in India also indigenous 2 vaccines are coming. They are under phase 1 and 2 clinical trials. So coming to the dengue vaccine, that is the one which has been permitted to be marketed in some of the countries from 2015. It is a live attenuated tetravalent vaccine by the Sanofi Pasteur. As I told you, almost about $2 billion are spent to get this vaccine since last 20 years. The research is going on since 20 years, and they could manufacture the vaccine, and it is permitted to be used in further immunization of the endemic areas. 2013, Mexico got the permission. Not only that, Philippines also got the permission. So individuals 9 to 45 years living in endemic areas, this vaccine is indicated. Normally, it is given a 3-dose schedule, 0, 6, and 12 months. The vaccine developed using a live attenuated yellow fever vaccine, that is 17D, as a backbone with chimeric Dengue vaccine candidates. I'll show you the picture where the yellow fever vaccine genes are substituted by all 4 types of dengue virus antigens. The PRM, as I told you, pre-membrane M protein and E genes from 4 dengue viruses. The 4 serotypes are there, no? Serotype 1, 2, 3, 4, substituted for those of yellow fever vaccine in contrast of genetic background of 17D vaccine. And it comes in a lyophilized form as a single dose or a multi-dose with a normal saline diluent. So this is the picture which is showing. The top one is the virus, the middle one is the genome of RNA of yellow fever 17D vaccine strain. What they have done is they have removed the PRM E protein, PRM and the E protein of yellow fever 17D vaccine strain, and they have incorporated the dengue virus 1, dengue virus 2, dengue virus 3, dengue virus 4 antigens, PRM and E antigens into the yellow fever 17D virus structure. And this is live attenuated virus with a tetravalent vaccine has been formed with using a yellow fever 17D backbone. So as far as the clinical trials are concerned, we always look whether the vaccine is efficient or not. Almost 5 Asian countries did the clinical trials, that is known as SID-14 trial, including 2 to 14 years of age, and SID-15 trial in 5 Latin American countries. The age groups are 19 to 16 years of age. And almost over 35,000 participants are there. And the randomized to the vaccine and placebo groups in 2:1. The vaccine efficacy was found to be almost 60% against the confirmed dengue in the year following the primary series. The pooled efficacy against the severe dengue is about 80%, and the efficacy varied for individual serotypes in a tetravalent vaccine. In fact, serotype 3 and 4 have shown the maximum seroconversion, that is almost 71 to 76%, whereas the serotype 2 is the lowest, that is 43%, and serotype 1 is 54%. Vaccine efficacy according to baseline serostatus. So what happened is, after introduction of the vaccination, what they have found is, so post-market surveillance has been done. What they have found is the vaccine in some of the seronegative individuals, if it is given, the vaccination acts as a primary infection. And when the child gets a secondary infection, there is a chance of having a severe dengue. So that's why they have done a post-marketing survival study again. The immunogenicity subsets of about 13% of the trial participants, and baseline serostatus was found with the PRNT technique. So with the serostatus, the efficacy of the vaccine for a symptomatic virus-confirmed disease of any severity is about 80%, but when it becomes a seronegative person, drops almost to the 52%, especially in the age group of more than 9 years. Whereas in the age group of 2 to 8 years, the seropositive individuals, the efficacy is 70%, whereas seronegative individuals, the efficacy was found to be only 14%. And there is a definite risk of having a severe dengue for those who have received the vaccine who are seronegative. So this has led to the position paper by the WHO in 2018 regarding the dengue vaccine. So WHO position paper says that seropositive efficacy is 72%, seronegative efficacy is 30%. So this is the highlight of WHO position paper in 2018. What they have said is there is an increased risk of hospitalized and severe dengue in seronegative individuals starting about 30 months after the first dose of dengue vaccine. And some have found that in an area where 70% dengue seroprevalence is there over 5 years follow-up of the post-vaccination, for every 4 severe cases seropositive individuals, there would be 1 excess case of severe case of seronegative per 1,000 vaccines. Not only that, for every 13 hospitalization prevented in seropositive vaccines, there would be 1 excess hospitalization for a seronegative individual who has received the vaccine. This is the statistics which they have found, and these are the various pictorial diagrams which are showing that the seronegative individual is more likely to land up with a severe infection if he has received the vaccination before the primary infection. So coming to the, as far as the seropositive, seronegative people having risk of having a severe dengue, the seropositive, it is only 0.29, whereas seronegative in 2 to 16 years age group is 1.65. So for the risk of hospitalization with severe dengue, relative risk of severe vaccine-confirmed dengue comparing to the vaccinated to the controls. In the 66 months after the first dose, it was found that seropositive people, the risk is minimal, that is 0.25, whereas if the patient is a seronegative patient who has received the vaccination, the likelihood chance of severe vaccine-confirmed dengue is almost 3. So there is always a risk of getting a severe dengue if the person is seronegative, received the vaccine. So with this information, so WHO position paper says that the live attenuated dengue vaccine has been shown in the clinical trials to be efficacious, safe in persons who had a dengue virus infection in the past. That means baseline seropositive individuals, but carries an increased risk of hospitalized and severe dengue in those who experience their first natural dengue infection after vaccination. That is baseline seronegative individuals. The country should consider introduction of dengue vaccine, SID, EDV, that is dengue vaccine, is only if you can minimize the risk of severe infection among the seronegative individuals who are receiving the vaccine. For this, WHO position policy has told that screen and vaccinate. That is one thing. Screen every potential vaccine recipient with a rapid diagnostic to determine serostatus. Only vaccinate those testing seropositive. That is one policy. And second policy is mass vaccination of seroprevalence threshold. That means vaccinated population in areas where the endemic dengue is there, where the transmission intensity exceeds a certain threshold, that is almost 80% of seroprevalence of positive dengue in up to 9 years of age. Suppose your community has 80% seroprevalence of dengue. That shows that most of the children had a primary infection age group less than 9 years. So this vaccine can be given if the seroprevalence is 80% without doing the pre-screening test. So for the countries considering vaccination as a part of their dengue control program, pre-vaccination screening is the recommended strategy. With this strategy, only persons with evidence of past dengue infection would be vaccinated based on the antibody test and or a documented laboratory confirmed in the past. For this, we have to do the screening test before giving the vaccination. But unfortunately, we do not have a specific screening test, which is almost 100% specific. So what happens is you may have some positive patients who are seronegative. In those patients, there is a severe risk of having dengue if you vaccinate them. So for this reason, so you need to explain, because the severity of the infection is more in a vaccinated individual who is seronegative at the time of vaccination. So given that no assay will be 100% specific, some truly seronegative individuals may be vaccinated with false positive test results. So furthermore, although the efficacy against the dengue infection, seropositive individuals is high, it is not still 100%. The limitation of SIT-TDV will need to clearly communicated to the population offered to the vaccine. So I'll tell you an example. In the Philippines, they have started a very ambitious program. Almost 800,000 people are vaccinated. School-going children are vaccinated. But following the report showing that seronegative individuals are likely to have severe dengue infection after the vaccination. So what happened is there was almost about 160 deaths were there, but only 18 cases were found to be dengue confirmed cases. So almost the negligible risk is there, but it was not explained to the parents. What happened is it led to a vaccine.
You have 5 minutes.
Hesitancy. So there is a drop in the vaccination in the Philippines. In fact, it is withdrawn from the Philippine vaccination program. So pre-vaccination screening is a must for the dengue vaccination. These are the WHO position. What it says that if pre-vaccination is not feasible, at least 80% seroprevalence should be there. And the age group of above 9 years, this vaccine can be given. And you should explain to the parents that there is a risk of severe infection if the child is seronegative by the age of 9 years. So these are the second vaccine which is available is the Tetravalent dengue vaccine, that is known as TAC-003. It is a live attenuated vaccine, provides, and in fact, it has a backbone of all 4 serotypes, and the 2-dose schedule, that is a 90 days interval, it is given. The trial is undergone almost phase 3 trial about Latin America, Asian country, 200,000 healthy children and adolescents between 4 to 16 years of age. This vaccine has been studied, and it uses all the 4, live attenuated strains of serotype 1, 3, and 4, whereas 2 is used as an antigen insertion into the other things. So I won't go into the details of these trials. Only thing is the secondary endpoint, what they have shown is it is almost efficacy rate is about 90% effective against the hospitalized dengue, and 76% vaccine confirmed dengue seropositive individuals, and 66% in seronegative individuals, and 85% against the dengue hemorrhagic fever. So one good thing about the Takeda vaccine is after 54 months of follow-up, they have shown that there is no evidence of disease enhancement was not observed. It was not observed. In fact, this is a heartening point. Definitely, this vaccine is likely to have a better performance compared to the Dengue Vaccine if it is marketed. So another vaccine is TB003, TB005, and it uses vaccine consists of dengue 1, 3, 4 as a whole genome, and dengue 2 is 2 antigens are inserted into that, and it is a single dose vaccine, and it is a completed phase 3 trials. So this is the structure of the dengue vaccine used by the NIH. So inactivated vaccine is manufactured by the GSK along with the American company, the WRRAR, and phase 1 trials have been completed. And this is a tetravalent E protein subunit vaccine developed. It is under phase 1 trial. And this is TVDV, that is tetravalent shuffled with used PRME expressed as a plasmid vaccine, and US Naval Medical Research is doing the trials. It uses all 4 steroids. Tetravax, the vaccines developed in India, a word about them. We are developing 2 vaccines, Tetravax DV. In fact, Panacea Biotech, BE, and Serum Institute are trying to develop this vaccine. The technology is from US NIH. This is a tetravalent vaccine. And DS4 is a vaccine indigenously developed, a protein-based tetravalent subunit vaccine. This is the DNA is integrated into the yeast, that is Escherichia pastoris. We know that hepatitis B is produced with this yeast, It encodes 4 copies of S and 1 copy of fusion DNA, and S and DS proteins are co-assembled as a VLP, vaccine-like particle. This is a subunit vaccine, which is going to be manufactured by the Sun Pharma. This is done by Sun Pharma. So these various molecules, how they are made. Tetravax DV is a tetravalent individual vaccine, whereas DSV4 is a recombinant vaccine where all the antigens are incorporated into the yeast, and then the antigens are produced and they are into the vaccine-like particles. So this is the first published paper as far as India is concerned. This year, that PATS-IAP has published our phase 1, phase 2 trials, which are showing the safety of the vaccine, and it is going into the phase 3 trials. And safety and immunogenicity has been proved beyond doubt with the tetravalent vaccine, which is produced by the PATS-IAP biotech. This is the one. So subunit vaccine, as I told you, it is manufactured by Sun Pharma with the help of Center Genetic Engineering and Biotechnology. A recombinant vaccine with a yeast used as a for the recombination technique. So coming to the introduction of the vaccine as far as India is concerned, with the WHO recommendation that you should have a zero prevalence of at least 80% to introduce a vaccine without doing the pre-test whether the child is had a primary vaccine with dengue or not. So overall zero prevalence as far as India is concerned, it is 48%. And if you see the increasing from 28.3 among the children 5 to 8 years, by 9 years, only 56% are positive. So this vaccine definitely cannot be introduced into India as a routine vaccination for all the children. Even if at all, if it is introduced in the endemic areas like southern India, where 76% of population are seropositive by end of 9 years. So in that situation, you have to do a pre-test, find out whether seropositive individual is there or not, then only this vaccine can be given. The vaccine Dengue Vaccine, which is available, and the age group is after 9 years, and presently it is given as a schedule 0, 6 and 12 months. And recently Philippines are doing a study with a single dose vaccine from 9 years onwards. So if it comes, if the efficacy is proven, maybe the single dose vaccine of Dengue Vaccine may be given. So thank you very much. Summary. So we know that protective immunity against the dengue vaccine is not fully understood. Infection with one serotype confirms long-lasting protection, whereas heterotypic infection can lead to the severe dengue. And dengue vaccine is the only vaccine licensed since 2015. And dengue vaccine is attenuated live tetravalent vaccine with a 17D yellow fever backbone. Efficacy is almost 80% in seropositive individuals, and seronegative individuals, it is 52%. There is an increased risk of hospitalization in seronegative individuals starting about 30 months after the first dose of dengue vaccine. WHO position paper on dengue vaccine recommendation is that it can only be used in the age group between 9 to 45 years in seropositive individuals or in communities with seropositive rate of 80% by the age of 9 years. Takeda vaccine T003 has completed the phase 3 trials. It is for the licensure. Indigenous live tetravalent vaccine has completed phase 1 and 2 trials. Thank you very much. Thank you, sir. Thank you for the opportunity.
Surender. Dr. Bhaskar, how much time we have? Dr. Bhaskar, how much time we have for further discussion? Well, maybe we can take a few questions. I had prepared a list of questions for the panel discussion, which was to ensure after this presentations. But you know, the fluency of the presentations was so precise that many of the questions which were in my mind and which were in my panelists' mind have already been answered by the eloquent speakers who have spoken before. So what we'll try to do is we'll try to take some questions from the chat box. We'll also try to answer some common, some stupid, some important, and some practical questions which we see in day-to-day practice. So we'll have about 20 minutes time. We'll wrap this up by 11:30. My panelists are Dr. Ajay Mohan from Gandhi Hospital, is the professor of pediatrics. Dr. Shekhar is a eminent pediatrician. He has been in general practice. He has run a nursing home. Dr. Nitin Chawla, is Dr. Nitin Chawla online?
Yes, sir, I am. Am I audible, sir?
Yeah, you are audible, doctor.
I'm not visible. My video is on, but I'm not able to. I mean, my video is on, but still I can not. I'm not been seen on the screen.
If the IT people have taken that point, please make Dr. Nitin Chawla visible, because we have not seen him and we are eager to see him on the screen. Yeah. So my question to Vijay Shekhar is, Vijay Shekhar, the speakers have eloquently taken such a importance to the WHO document on dengue fever, and they have touched upon various aspects of dengue fever based on the WHO document. Can you just give us a brief idea of what the classification of dengue is?
So the present classification differs from the previous classification, which said dengue fever with or without hemorrhage, and then dengue hemorrhagic fever, and then they divided hemorrhagic fever into 4 parts. Now, dengue, WHO has simplified it. It says dengue fever with or without warning signs, and dengue, severe dengue. Severe dengue encompasses the entire gamut of dengue infection, which requires care in terms of hospitalization and more focused care. That also includes the dengue hemorrhagic shock syndrome. What is not very clearly included but understood is that expanded dengue syndrome also would come in the severe dengue. Expand, by saying expanded dengue syndrome, what we are in effect saying is it has not only affected the plasma leakage, it is also affecting the organs like the brain, heart, kidney mainly, and also sometimes some other parts. This is in short the classification, and it is very useful from a point of view of clinical practice, because it clearly differentiates who needs to be admitted and who needs to be kept in an OP basis, and there's a clear demarcation of who to say has severe dengue fever. The 7 warning signs are very clearly mentioned, and if they are there, it is severe dengue.
Thank you, Shekhar. One question to Dr. Dania. Dr. Dania, if she is online. Yeah, if Dr. Dania is not online, Dr. Vijay is online. Dr. Vijay, the question is for you. I was going through the WHO document, which says that congested pharynx is one of the commonest clinical presentation of dengue, and GI manifestations, in fact, are more than the headache and myalgias. Your take on this, Vijay? I was a little taken aback.
So, as I discussed before, the presentation would vary from age to age. Typically, in very young children, you do have this pharyngitis-like illness as a common manifestation of dengue fever. And that is what I said, that most of these children we do not diagnose as dengue, and they are treated like any other URI. And congested pharynx is seen in these young children. If tomorrow I were to start doing NS1 all these children, I'll not be surprised that many of them would turn out to be dengue NS1 positive. However, given the fact that these are self-limiting illnesses, one really need not worry about it. And GI manifestation, yes, we do come across GI manifestation also, but at least in my personal practice in the last several years, I have not seen GI as a major presenting manifestation of dengue, though there is a mention of it in the WHO handbook.
Vijay, a word on what does dengue hemorrhagic fever mean?
Dengue hemorrhagic fever was typically described as per the old classification, where they describe primary dengue and secondary dengue. And dengue hemorrhagic fever is one which is associated with those 2 cardinal manifestations of capillary leak and abnormal hemostasis. So many of these children had hemorrhage, which again, let me reiterate, not related to thrombocytopenia, but because of abnormal hemostasis. Now, from management point of view, the WHO gave up that classification. And as Dr. Vijay Shekhar said, it has been beautifully now classified, which has gone a long way in helping the clinician manage this case as well. Probable dengue with or without warning signs, and severe dengue.
Thank you, Vijay. Dr. Vijay in his presentation very rightly said that in a season of dengue, every acute febrile illness should be suspected of dengue until proven otherwise. Dr. Ajay, in clinical practice, whenever you see a febrile child, what are those pointers which point that probably this is not dengue, this is something else?
There are many conditions that can mimic dengue. A plethora of conditions. Let me say that a minor illness like a flu-like symptomatology, flu-like illness to a major illness like acute leukemia presenting in blast crisis can mimic a dengue. Sir. Again, when we are actually seeing, suppose there are certain conditions that mimic febrile phase of dengue, and there are certain other conditions that can mimic the critical phase of dengue. For example, if you see the febrile illness, febrile phase of, we usually come across in dengue in the febrile phase with fever, with rash, with myalgias. So one possibility is that are we dealing with chikungunya? Are we dealing with any viral exanthems like measles and rubella? Or are we dealing with any bacterial infections like leptospirosis or typhoid? Malaria is always a possibility where we can think that this child can have malaria, or are we dealing with febrile phase of dengue? And there are other conditions, sir, with let me say like autoimmune diseases and meningococcal disease, meningococcemia. All these febrile conditions, all these conditions with viral exanthematous rash can present like febrile phase of dengue. Now, coming to the critical phase of dengue, where the child can present with acute abdomen. We have seen cases like the acute appendicitis. In fact, they directly land up in surgical ward rather than in the pediatric medical wards. And we have seen cases that are undergone laparotomies, which because they couldn't differentiate between the critical phase of dengue because they present with acute abdomen, acute appendicitis, acute cholecystitis, perforated viscous. All these can mimic dengue, sir. So, and one more thing is, last thing I would like to say, I have seen a case where the junior resident was almost putting like dengue, and we have, for some reason, the child had thrombocytopenia, but the case was a diabetic ketoacidosis, and one of the differential diagnoses was the first possible diagnosis was dengue. So we have to be very, very wary of all these things. What exactly are we doing? Whether we are doing with the febrile phase of dengue or with the critical phase of dengue, and are we dealing with some other conditions that may mimic dengue?
Thank you.
Can I add, Sanjay, one point?
Sanjay,
Yeah, Surendra, please go.
Sanjay, if I may add some practical tip to what Ajay said.
Absolutely.
In monsoon, you see a lot of acute febrile illnesses, and there is a great deal of overlap. So a quick thing on day 3 of fever to do is CBC, CRP, and NS1 antigen. And if resources permit, and if the epidemiology is talking about leptospirosis in the region, you add serum creatinine. So you look at these 3 parameters. High CRP would by and large rule out dengue fever. You have high CRP in enteric fever. You have low hemoglobin in malaria. You have thrombocytopenia and low counts, which set in very early in dengue illnesses. You have thrombocytopenia with elevated creatinine, let your antennae be up for leptospirosis. If because these are almost rapid diagnostic tests which are available. And NS1 antigen, as I said, is highly specific test, provided it is done on a WHO standardized kit.
Vijay, a quick question from the audience. Missy is a Badnaam Munni now. You do a serology for COVID, everybody comes positive, and anybody who has fever for more than 5 days can be theoretically labeled as Missy. What is your take on Missy and dengue, Vijay?
One has to be extremely careful. Yes, cytokine storm and the pathophysiology, there is some degree of overlap between Missy and the critical dengue. However, there are certain features which are very peculiar to your Missy. So one should not end up doing serology in one and every patient that presents to you, because given the duration of the pandemic and the prevalence, almost each and every child would test positive for antibody. And antibody positivity does not really mean anything unless you have a clinical setting where you have, those classical features of MIS-C. One should not, mix up dengue, critical dengue with MIS-C.
Surender, you wanted to add something?
As far as the clinical presentation is concerned, in the present scenario, I mean, what we are seeing on the OPD, there are 3 types of cases are there now. One is coming with a high-grade fever on the day one, with severe myalgia. Child looks very sick and retroarticular pain. High pain is headache and retroarticular pain. Most probably 100% you are dealing with a dengue. Whereas other respiratory infections, usually they will have a prodrome of URTI or some little bit of congestion in the throat. Whenever there is no focal signs, with a high-grade fever, with myalgia, with high pain, headache, 100% it is dengue. I think we need not do any test. Ask them to come for follow-up every 2 days. Reassess the child. Reassurance. When you write a paracetamol like Vijay said, they're not convinced. So you should ask them to come every 2 days and reassess the patient and take the steps as investigations are required. On the 2nd or 3rd day, you can confirm dengue or not. Then the present scenario, we are seeing these 3 types of cases: URTI, high-grade fevers, and some of them are other tropical infections are there. And the difference from the last epidemic is the fever is not coming down. It is almost continuous nowadays. It is not coming down with paracetamol. Most of the parents are complaining that fever is continuous in spite of using paracetamol. So the presentation has changed a little bit in this. Definitely in this.
Yes. Surender, I would always take dengue, a child who is very dull, a mother who says that मेरे बच्चे को बुखार इतने दिन से आया मगर this bukhar is something different.
Yes.
The mother who complains that the child is presenting with headache. I would always think twice before telling dengue if it's an active child, if the child has no rash, if the child has no myalgias. I think these are take-home clinical situations. Thank you so much, Surender. Vijay Shekhar, a question for you is...
Madam wants to add something then.
Thank you. I just wanted to add to what Dr. Yevle sir said for a query regarding differentiation between severe dengue and MIC, because I've been looking at a few studies which have compared both, since they have similar manifestation of fever, they can have both cytopenia as well as severe hepatitis. But what they all conclude is the mucosal involvement, like the cracked lips and strawberry tongue, conjunctival effusion, as well as the ferritin level is less in dengue, but inflammatory markers such as CRP is more in MIC. It's highly raised in MIC compared to dengue, where you don't see markedly rise in CRP. And the coronary abnormalities, of course, go in more favor of MIC. So oral mucosal changes, raised CRP, and coronary abnormalities more common for MIC. Hyperferritinemia more common for dengue. That is what the literature suggests.
Thank you, Dr. Dania. Thank you for joining us also. There was one question I had framed for Dr. Vijay Shekhar, but I would like your opinion on this, is that these infectious diseases are very funny in the sense that the vector is the same, but they don't occur at the same time. For example, malaria, leave alone malaria, Aedes transmits chikungunya also, chikungunya and dengue fever. Why we are not seeing so much of chikungunya now, though the vector is the same? When malaria happens, dengue is not seen. When dengue happens, malaria is not seen. When dengue happens, chikungunya is not seen. Any take based on your experience in infectious diseases?
That's an interesting question, but actually we have not been seeing chikungunya, but now since past 2 years, I think Dr. Yevle sir will also agree, actually we are seeing a rise in chikungunya cases in Navi Mumbai. I don't know whether it is because of the awareness increase also, and then you test for chikungunya. That, I mean, we might have missed chikungunya in the past. We do not know about that. But regarding malaria, yes, definitely the mosquito is different. But despite that, I would say the malaria actually has gone down. But falciparum is the one which has gone down. And surprisingly, but Vivax has become commoner, especially in the urban areas. And Vivax is behaving like severe malaria. So yes, there are few things which are beyond any kind of a factual explanation. Why is Vivax going up and falciparum going down, despite it being the same mosquito? Why is chikungunya not as common as dengue, despite it being the same mosquito? And but I don't think the mosquitoes are there to stay, despite all the vector control measures. And it's only the vector-borne diseases are only rising, especially dengue now across the country.
I think there's so much to learn about infectious diseases. The bugs are fairly as smart as we are. Dr. Vijay, you have to add something. Yeah.
If I may add, I mean, there are a few things. One thing is the construction activities and, better mosquito repelling measures observed by individuals, because there is a mindset that mosquitoes bite at night. And maybe that is one reason which is contributing to drop in malaria and very effective national malaria control program. Whereas dengue mosquito is daytime biting, clean water breeding mosquito. That is one. Secondly, talking about why one goes up, the other goes down. It's sort of this is my thought that there's an ecological balance that nature tries to strike. If you look at the number of viral infections that we are getting post-COVID, you have influenza, you have dengue, you have recurrent viral infections. I've never seen in my life so much of back-to-back viral infection in a span of 30 days in a child. You have almost every child coming back with second infection, flu-like infection within a matter of 1 month. So this is something all the viruses were suppressed when COVID was around, was not allowing any other virus to spring up. Similarly, if you look at the hand-foot-mouth disease outbreak, the polio disease went down, and then the niche was probably filled by the other enterovirus, and we started seeing hand-foot-mouth disease. I don't know, just thinking aloud. That I would agree with this.
I think the bugs have a mercy on the pediatricians. There's one question to Dr. Nitin. We have touched upon fair amount of warning signs and comorbid conditions. What is your take on obesity as a warning sign for dengue fever? We see quite often that obese children fare fairly unwell. Their prognosis is not so good as non-obese individuals. Dr. Nitin Chawla.
Sir, good afternoon. Good morning. Basically, in obesity, the white adipose tissue in the body is more as compared to the young lad of the same age group. Now, these white adipose tissue in research have shown that the inflammatory mediators generated during not only in dengue but any other illnesses as well will be high and more. And because of increased generation of inflammatory mediators, it is hypothesized that they will become more sicker, and that is the observation. Although the research is still undergoing and there are not very conclusive or very strong research, but whatever is there and literature available, it is in favor that yes, obese children will be having severe presentations. They will be more prone for having complications, and progression of disease will not be a simple one. So like all of us are always doing health checkups, in that is, I think, the overnutrition pandemic is looming around our in our society, and we should be giving proper input to the parent to take care of that aspect as well. to come to the question directly, yes, it has some association, but not strongly associated, and further research need to be done in this topic, sir.
Thank you so much, Dr. Nitin. I had so many questions, but we have overshot the time by 30 minutes actually. So what we'll do is we'll try to take 2 questions from the audience on serology of dengue. Now, quite often we do the IgG, IgM. Is there any relation IgG, IgM, doing both IgG, IgM on the prognosis of dengue? Dr. Ajay.
Sir, as far as the IgM is concerned, we have, as earlier speakers have told us, that the IgM will rise only from the 4th or the 5th day during the critical phase, sir. And and at that time you don't see the IgG. IgG has a little late response during the recovery phase. But when you see IgM and IgG together increased, then we have to always suspect a secondary dengue infection, sir. So in primary dengue, you see only the IgM first and a little later the IgG. But as secondary dengue, IgM and IgG together will raise simultaneously, and probably that will have a adverse effects that may give a prognostic distance.
Thank you, Ajay. You have hit the nail on the head. This will be the last question because all of us have so many other things to do and we are near 11:30. The question is to Dr. Nitin Chawla. One of the audiences asked on how to monitor the intra-abdominal pressure.
So basically, intra-abdominal pressure is monitored.
Can you be as brief as possible? It's for the general practitioner.
Sir, it will be a very difficult task for a general practitioner to monitor intra-abdominal pressure, but there is one way which how they can use it. So we have to make a transducer by using Foley's catheter. There are charts available for intra-abdominal pressure monitoring. It should be less than 7 as for a dictum to understand. You put a Foley's catheter, take a 3-way cock assembly, attach 20 ml syringe to it, make a channel through it with this so that the pressure grading is maintained. That constant flow along with the transducer being set at midline at iliac crest at mid axillary line will give you a baseline. Monitor after 60 seconds of starting this assembly. If you see that the pressure is increasing and it is going beyond 12, that is the time when the red flag should start coming to your mind that now the child will go into a couple of organ dysfunction, mainly pancreatitis or hepatitis will be more, and chances of shock will be high. If your assembly is not being zeroed well, then there will be misleading results and you will not be able to monitor it adequately. For that, just make sure that the Foley's catheter is in connection with the IV, with the monitor, with the probe. Arterial probe should be calibrated, and the channel, there should not be any air in between. Usually syringe with 20 ml is useful enough to make the entire channel and for monitoring purposes.
Thank you, Dr. Nitin. I'm sure Dr. Preeti, who has asked the question, has understood. But from my end, if I get any child for whom the intra-abdominal blood pressure has to be monitored, I would either refer to Dr. Anupama or Dr. Nitin. Thank you so much. We had a very wonderful time. There's one take home for the Twin Cities is that when we next plan for dengue session, it should be a half a day session, not a 2.5 hour session. Thank you so much, Vijay. Thank you so much, Dania. Thank you, Surender. Thank you so much, Anupama. Thank you, Ajay. Dr. Nitin Chawla, it's nice hearing you. Dr. Vijay Shekhar, nice joining us. Thank you so much. Over to Dr. Bhaskar.
Yeah, thank you, Dr. Sanjay Srirampur. It was a really very entertaining, excellent, and educative. And I'm so happy our guest speakers are equally enthusiastic and they stayed until the last minute of the activity. And my thanks to all the faculty members who have spared their precious 3 hours time for maybe 2 to 3 hours for this symposium. My special thanks to all the panelists, and also special thanks to the participants. And when I looked at the participants, there were around 60 at around 9:30 a.m. and there are around 50 persons now. And simultaneously, there's a recording on YouTube channel. I'm sure many people will take an advantage of looking at it YouTube at a later period at their convenience. So I could see some seniors as well staying until the last minute. So thank you once again. Thank you all, and wish you all a great happy Independence Day tomorrow and Azadi Amrit Mahotsav. Thank you very much all on behalf of entire IAPTC.
Dr. Bhaskar, we are jealous of you. Have a nice weekend. Safe drive.
Thank you.
Thank you.
For Kuchipudi Natam today.
Thank you,
Thank you,
sir.
sir. Thank you.
So thank you very much, sir. Thank you, Dr. Sanjay sir, for especially for directing and producing this beautiful movie. So we will have Dengue 2 at a later time. Thank you one and all. Have a happy Sunday.
మీరు కూడా ఆ కార్లో వచ్చేసేది తీయడానికి ఇబ్బంది ఉంటుందా?
ఏం లేదు,
అసలు బ్యాక్ సైడ్ కూడా ఉన్నది ఫ్రంట్
చేసేది అంటే
అత్తమ్మ కూడా ఏమంటున్నారంటే మీరు 4 మెంబర్స్ ఆ కార్లో వచ్చేసేయండి, మేము బైక్ కొనొస్తాం.